Thank you. Good morning. Oh, let's try that again. Good morning.
Good morning.
Getting better. Welcome, colleagues, friends, SCAS newbies, SCAS virgins, SCAS oldies. It's my pleasure to welcome you to, and wait for it, we need to raise the roof with this, SCAS26! I can see some of us need to still hit our stride this morning, but thank you for that. And thank you for my little indulgence there. Back in Black, AC/DC's possibly greatest album, and I always like to come down to that. So, welcome to the symposium that's all about trying to improve outcomes after out-of-hospital cardiac arrest, about more neurologically intact survivors, about better decision-making around resuscitation, and about caring for those who are affected by cardiac arrest after the fact. And we are really, really pleased that you're with us today. And it's my job just to give you one or two introductory remarks. First things to say are there are no planned fire alarms. Do we have anybody from Scottish Fire and Rescue in the room? We occasionally do. I was going to suggest if anything goes wrong, follow them, but none of them are here yet, so just head that way towards the fire escapes, and it's a short exit out. There are one or two other practical things I need to say to you. We're doing things slightly differently this year. We have a data walk. We have a data walk. What's a data walk? I hear you all cry. Well, a data walk is a way for us to get you to engage with and to talk back to some of the data around out-of-hospital cardiac arrest in Scotland. So as you walk out to the sponsors, if you nip down the side corridor, you'll see some posters on the wall. And each one of those has a piece of information about how things are currently in Scotland and about how things could be in the future. We want you to look at them, pick up a pen, and write on the posters your reaction, your experience, whether you agree or whether you disagree. And we're going to pull all of the responses together and talk about them after lunch. So please go and interact with the data walk. You can do that on your way to interacting with the sponsors. We are really pleased that every year we've managed to make SCAS free. And we only managed to do that because we have excellent sponsors, platinum sponsors all. We have Stryker, Otis, Corpulse, and others who are kindly paying for your lunch. So in return, we want you to go to their stalls and say hi to them, have a look at the shiny stuff they've brought to show you. So, data walk sponsors. Your name badge. If you just pick up your name badge and have a look at the back side of your name badge, you'll see some important information there, all in the form of QR quick response codes. And there are two things I want to draw your attention to. The first one is feedback. We'd love it if you could give us some feedback on the day, what you've learned, what we can do differently next time. And also if you could stick in your email address if you want to keep in touch. Scottish Cardiac Arrest Symposium isn't just a day in a room. Well, clearly it is a day in a room, but it's not just a day in the room. It's also an ongoing conversation. And if you leave your email address, we will be sending you links to videos that we'll put online. All of the talks from today will go online. And the continuing conversation about how we improve outcomes after cardiac arrest. Because we really want to help you guys be the best resuscitators and system organizers and supporters that you can be. It occurred to me the other day that when a bystander phones for help, somebody's had a cardiac arrest, the call handler says, don't worry, help is on the way. Just carry on compressions, help is coming. And what we need to realize in this room is, you are the help. The cavalry is coming and you are the cavalry. And that brings with it some excitement, a sense of purpose, a sense of real opportunity to make a difference, but also a weight of responsibility and sometimes a bit of anxiety. So the Scottish Cardiac Arrest Symposium is here to help make you, to help make us, the best cardiac arrest resuscitators we possibly can be. So, I want to welcome up Professor Barbara Farquharson, sorry Barbara, who is going to chair this first session for us. Thank you, Barbara.
Morning, everyone. I've presented here a couple of times, and I always find it a really inspiring and energising conference, but I didn't have anything interesting to present this year, so Gareth thought he would put me to work doing awkward introductions, so my apologies. But I'm really thrilled to introduce our next speaker, who is Professor Andy Lockie, and he's a consultant in emergency medicine at Calderdale and Huddersfield NHS Trust. He's president-elect of the ERC, so very important, and a colleague of mine on the ILCOR EIT task force, where we do systematic reviews relentlessly. So I'm going to hand you over to Andy.
Thank you very much, Barbara, and thank you, Gareth, for outing me as a SCAS virgin. I really do appreciate that. Any other virgins in the room? No, thought not. So I'm gobsmacked. This is the first time I've come up here. I've heard so many wonderful things about this meeting. Really looking forward to today. My name is Andy. I am a Yorkshireman with a Scottish name, so free meeting, free food, that really does appeal to me. Thank you so much for that, Gareth. Although I checked my DNA, I am actually 6% Scottish. I'm also 6% Viking, obviously, and 20% Irish, and more percentage than I care to admit French as well. So you can guess that I'm a mongrel from various sort of people visiting the Sceptred Isles. My invite is to talk about the past, but I'd like to sort of link that in a little bit with the future as well, because Scotland has always been on my radar. I'm the immediate past president of Resuscitation Council UK, and we even appointed a Scotsman as our chief executive officer. We were that desperate. But we have always been aware of the Scottish excellence. And I just want to share a little bit of that with you in a few minutes. So what is the position of Scotland when compared with the rest of UK and with the rest of Europe? Let's do a little bit of data first of all. I know that we all like numbers and we all like a bit of data. So the immediate comparator is to look to something called the Eureka 3 database. This is a Europe-wide database of 48 countries, looking at 44 countries, looking at the data around survival from out-of-hospital cardiac arrest. This particular database was run in 2022 over 3 months, and it's a registry of 28 out of those 44 countries. Now, it's very difficult to do comparisons because a lot of countries have got different ways of inputting data, of what they actually say is legitimate data as well. So there were less than 50% of countries with complete data sets. But if we look at those countries where the data is almost complete or complete, what does it tell us? So in 2022, the 30-day survival from out-of-hospital cardiac arrest was 7.1% across Europe. In England, it was 7.3%. But what about Scotland? 8.7%. So immediately, you can see that you are well above average, well above England as well, which always matters. So you're obviously doing something really good. And that's my first and most important message, is that Scotland is leading the way and has got a phenomenally better survival rate than the vast majority of Europe. But there's this bar, there's this mythical decimalized bar of 10%. And it's something that we do tend to get very obsessed with. So you'll see that the vast majority of those survival rates hover around or mostly just below 10% 30-day survival. There are a few outliers, and clearly Scandinavia is and always has been well ahead of us. And we're constantly looking towards Scandinavia to understand why. But the vast majority are hovering between 8 and 10%. And when we look at your own report from SCAS, this is one of the big infographics. 1 in 10 survive to leave hospital after out-of-hospital cardiac arrest. Now, it's an important thing that you can only improve what you measure. That's the mantra that comes out of the Global Resuscitation Alliance. And it is true. We need data. We need numbers to be able to improve. And simple messaging is good. And we like the number 10. And in journals, how many of you have either seen this or indeed written this? Survival rates from out-of-hospital cardiac arrest remain stubbornly low in the UK, with fewer than 1 in 10 people surviving. It's a number that crops up again and again and again. That's okay. It is one that's easy to remember. It's simple messaging. But in many ways, it's almost shaming people to improve, because we can't get just above that 10%. And the limitation of this is the needle doesn't actually shift that much year on year, and it can feel frustrating that we never top that 10%. So today is all about shift happening. We're going to talk about how shift has happened, but how do we make shift happen in the future? Well, there's good news here, because like the venerable Scottish Time Lord, you've already done the things that are impacting in the past that are impacting in the future. So what sort of things have you already been doing? Well, first of all, having a strategy. I know it sounds very trite, but strategy is absolutely essential. And the work that you've been doing over the last 10 years and beyond, finding ways to improve survival, that investment is really starting to show now. One of the things that you should be absolutely proud of is you were the first of the 4 nations to make CPR training mandatory in schools. This is probably one of the single most effective interventions that you will ever have. You are now training the future. You are training people how to manage a cardiac arrest from school age. And this was back in 2019. Westminster followed a few months later, and then Wales, and then finally Northern Ireland. So I'm particularly proud of the fact that we in the UK now have a mechanism for teaching every child CPR, and that is fundamental to improving survival in the future. Linkage in with Good Sam. Again, it's this multifaceted approach to being able to improve outcomes from out-of-hospital cardiac arrest. One of my other hats is I'm co-chair of the ILCOR's World Restart a Heart initiative, so true global domination. We had a meeting last night, and it was amazing to hear from all around the world the various examples of how we can improve bystander CPR rates. Heard from India, where we saw a picture of a pitch with 2,000 mannequins, 20 and 10 rows of 20 mannequins. Times that by 20 rows of 200 mannequins. They were training 20,000 people in one day. They've subsequently heard that the Guinness record is 24,000. So they're going to go back and do it again and do 30,000 people in one day. So that's your challenge. But I mentioned that I was up in Scotland, and Scotland has had a phenomenal history of engaging with Restart a Heart as well. So again, these are all bits and pieces. Your work about making pads count, the pad database that you've got up here, the pad map, all of these are creating ripples. Ripples that will have an impact into the future on cardiac arrest survival. But it's not just about data and numbers, it's about people. We focus on data a lot, but every person who survives is a valuable person. And I just want to briefly talk to you about a good friend of mine, because personal stories always really anchor it back down to where it matters. On the left is a gentleman called Neil Davidson. He lives locally to me. He survived a cardiac arrest in 2017. But for now, this is not his story. I want to tell the story of his son, Ollie, who stood on the other side. So Ollie learnt CPR in a local school in 2008. So that's even before the campaigns to get CPR onto the curriculum. It was a very forward-thinking school. Once he left school, he emigrated to Australia, where he worked in the events management business. He came home to visit his parents, and on the last night, they went out for a lovely pub meal. At 3 o'clock in the morning, he was woken to hear hammering on the wall. It was his mother who was hammering to get him to come through, because she'd woken up to find Neil breathing differently. Ollie went through and found that his father had had a cardiac arrest. Now, Neil is not a small man, but they managed to drag him onto the floor. Ollie did CPR for 15 minutes before the ambulance arrived. Now, their house is hidden in plain sight. I couldn't find it when I went to go and visit them. And it was a horrible night. It was raining. And essentially, it was 15 minutes before he had the defibrillator applied. And he survived. In 2019, I was invited to speak at a conference in Sydney. And Ollie was working just up the road in events management. And he came and told his story. And Neil joined us by video link. And it was a phenomenal moment. And afterwards, I noticed that Ollie was chatting to a friend of mine who's a professor of nursing in Sydney. Move on a year. Ollie's at nursing school. Total change of career. Really enthused. He's now a cardiology nurse. What about Neil? He's gone on to do amazing things. He's set up a local community CPR fund. He funds over 1,000 people a year to learn how to do CPR. He's contributed to numerous public access defibs, and this is him last week at Windsor Castle with his wife when he was awarded an MBE. We know for a fact that 6 lives have been saved directly due to the activities of Neil. So, 6 people who've been brought back to tax-paying status because of what Neil did. But that's only because of what Ollie did. And who knows, in Ollie's career as a cardiology nurse, the number of people that whose lives will be saved because of what he does. But this is where the shift happened. He was taught CPR at school. Because he was taught CPR at school, 9 years later, he put those skills into practice for his father, because we know that 80% of cardiac arrests happen at home, who has then gone on to save numerous people. It's not just ripples, it's waves. And that's why I'm saying the work that you have done in the past to train even just one child has got such a profound effect moving forward, and the benefits you can't even predict. So let's just briefly go back to the data again. And this is the graph from the report from you guys showing the 30-day survival trends over the years, particularly since you started doing the work here. And this is what you see. It's getting better year by year. Yes, we had the COVID years, and that did impact. And then we had this blip, which I'd love to know what happened when it went up to 10.9%. But essentially, year on year, things are getting better. And that's because of the things that you've already instigated. But it's not just about stats, it's about real people. And the number of survivors per year because of what you've been doing. So before this sort of strategy was put in place, 225 a year, now 338. So that's an increase in numbers of 113. And I don't know, how many people do we have here today? 300. So that's the number of people you see in this room today. That's the number of people who are currently surviving per year in Scotland because of the work that you're doing. And it's very easy just to think about the increment, but it's not. This number, every year, new, different people who are surviving. And that is awesome. But we come back to that 10% thing. We come back to that ceiling. How do we break through that ceiling of 10%? What shift needs to happen to get us above 10%? And I know that you've aimed to have 15% survival. Again, we're going along the decimalisation route. We like numbers in tens and fives. But here's a thought. What if you don't get above 10%? Does that mean that you've failed? Well, I put it to you that the work that you're doing, it may be that this year we have 338 people who survive. Next year we have 338 who survive. But what if next year's 338 have got, on average, a better outcome in terms of quality of life? So it's not just about looking at the big numbers, but it's looking at whether we're actually resuscitating people to a really good quality of life. And it's important that we look after survivors and that we optimize their recovery, because it's not just a simple binary switch where somebody survives. There are challenges. There are physical, there are cognitive, there are psychological challenges. And if we can improve the outcome of survivors, either through the care that we give or by optimizing the resuscitation so they get instant CPR of high quality, very swift defibrillation, whether it's due to a pad or whatever, or getting the emergency services quicker, then maybe, even if we don't top the 10%, we can make sure that the quality improves within that cohort. And I just want to briefly mention that yesterday, Resuscitation Council UK introduced a call to arms to help survivors, called The Weakest Link, and it's on the Resus Council website. And it's just really reminding all the policymakers, we need to give every survivor the right chance for survival. So some closing comments. Shift has happened for the good. You have already trained a sleeper cell, an army of people who are out there waiting to be activated to do the right thing when they come across a cardiac arrest. And that's very important. They may never use their skills. They may use it in a year, 2 years, 5 years, 10 years, but they have those skills for life. So never underestimate the power. There is no problem with aiming high. Please aim for as much improvement as possible, but don't set yourself up for a fail. It's okay to shift the dial by 1. So even if you're aiming for 15%, going from 10% to 11%, that will still see a significant number of people whose lives will be saved in addition to now. So break that curse of decimalisation. Be satisfied with 11% en route. Most importantly, don't be complacent. Keep doing the hard work that you're all doing. And remember, it's not just about the quantity in the number of people who survive, but it's also about the quality as well. And just one last thought on a hugely important strategy for success. Please. Thank you very much. Thank you. Is that on time?
Take questions or?
Yeah, I could, yeah.
Thank you, Andy. That was a fantastic start to the morning, and uncharacteristically, you're 5 minutes behind. I think we started early, probably because I didn't see all the things I was supposed to see.
That's unlikely.
But so we do have time for a couple of questions, if anyone has a question for Andy. Don't be shy. Yep, over here. Thank you.
What is it they're doing in Norway?
I would love to. I thought you were going to ask what it's doing in Norway that results in me having 6% Viking genes. I think it was not what they did in Norway, it's what they came over and did in the UK that created that. They've been ahead of the game for a while in terms of, first of all, they put CPR onto the national curriculum. Sorry, Scandinavians. I don't want to conflate Norwegians with Danish, with Swedish and Finns, but as a whole, their culture, they've been looking at this a lot sooner than we were. And they've been doing the right things around putting CPR onto the curriculum. But there must be a load more things. And I know that there's been a lot of work done. And it's not just Scandinavia. Seattle, they've been doing phenomenal work for many, many years. It takes a system to save a life. This knowledge that it's not just about one unique element, but it's just getting all the bits of the jigsaw in at the same time. It's getting the holes in the Swiss cheese aligning so that you can see the planets aligning through the holes in the Swiss cheese. It's getting every single factor together and getting those different stakeholders to work together. And that's why this is phenomenal. The program for today, the sort of things you're going to hear today, really look across the board of different stakeholders. That's what we need to be doing. We need to be improving the individual elements, but also how those all tick together to improve outcomes. So yes, we will catch up. It has to be said that some of that data, you'll see the confidence intervals were quite large, which does imply a certain amount of inaccuracy of data. So we want to see, just like here in Scotland, some really sort of good data that shows that things are improving.
Thank you. Great question. Do you want? Can people hear at the back without the mic, or shall we wait for the mic? There's a mic coming. There we go.
Does the research take into consideration the appropriateness of CPR as an intervention for these patients? So is it 10% of patients with 50% of them not being an appropriate candidate?
Yeah, and I think one of the things, that's a hugely good question. I think one of the things that has probably helped in terms of survival rates, it's not so much what we do, it's what we don't do. So we've got better now at having conversations with people about what their preferences are. We've got better at things like conversations around DNA CPR, so that we're no longer just jumping on the chest of every single person who has a cardiac arrest. So that does improve the denominator to some extent, because if you're no longer sort of jumping on the chest of somebody who has quite clearly been dead for 12 hours, then that will improve the statistics as well. But it's not just about statistics, it's about the dignity and it's about the appropriateness of doing an intervention in the right group of people. And if somebody has expressed a preference and has a DNA CPR or some sort of living will, we need to be understanding and respecting that. So I think the data is a lot cleaner nowadays because we're more cognizant of those conversations, and it's important to have those conversations within the healthcare system.
Thank you. That's our time to move on to our
Have a fantastic day. I'm really looking forward to the remainder of the presentations. Thank you for inviting me.
Thank you so much, Andy, and for emphasising all the incremental changes that need to happen for lives to be saved, which leads on very nicely to our next speaker. Dr. Els Freshwater is the APCC clinical lead in the Scottish Ambulance Service. She's previously worked in England and Australia as a paramedic and emergency medicine ACP, and been an educator in various higher education and clinical settings. So she's here today to talk to us about ALS optimization. Thank you very much and welcome.
Thanks very much, thank you. I made it all the way to the stage without tripping up, so that's my first anxiety dealt with. What a brilliant conference. This is my first time. I'm a SCAS newbie, I'm going to say. But it's really great to see so many people here in the room, but also online, who are joining us, people who really care about looking after our patients and doing really good resuscitation to improve outcomes in cardiac arrest. Just want to say a special hello to the people who are online, especially the ones in the Highlands and Islands. So it's nice that this is accessible to people as well, and we can get this out where we need to. So, my second anxiety has got me. There we go. So my name's Els, I'm a paramedic, and what I want to talk to you about is quite a simple principle, really. I don't think it's controversial at all. What I suggest is that if we're going to do resuscitation, that we do it optimally, that we do it thoughtfully, deliberately, and with precision. So you'll all know there's a whole load of new JR Calc updates that have come out recently that talk to us about the way that we approach the patient who is in cardiac arrest. And within those guidelines, there's a lot more flexibility to think about frailty, comorbidity, patient's wishes, futility, the appropriateness of resuscitation. And you're going to hear a lot more about that from Shorty after the coffee break. But the flip side of that is when we think that resuscitation has a chance of being successful, we're going to do it well, we're going to do it properly. We've got 45 minutes, we're going to implement thoughtful actions, and we're going to really give that patient a chance. And so that's what I want to talk to you about. I'm calling it precision resuscitation. Or the alternative was, if you're going to do it right. I was slightly anxious about putting some dodgy 1980s music references into my presentation because I appreciate there's a subset of the audience for whom this will be irrelevant. But then Gareth walked on to Back in Black, so that's fine. This is George Michael, Andrew Ridgeley, and their absolutely fabulous hair, which I hope you can just take a minute to appreciate. But this is Wham, okay? And they said, if you're going to do it right, and that's what I want to think about. If we're going to do resuscitation, we're going to do it properly. We're not just going through the motions. We're not just carrying out an algorithm or a checklist and looking at our watch and deciding when we can stop. We're going to make some really sensible clinical decisions and decide that this is either a resuscitation that is going to stop, which you'll hear about later, or this is something that we're going all in and we're doing it thoughtfully. So what are we going to do? Well, let's do some CPR. Let's make a start with some CPR. But we're going to do really, really high quality, consistently good CPR. So we're going to do CPR that is appropriate rate, it's appropriate depth, we're getting full recoil of the chest, we're minimizing interruptions to our CPR. The heart stopped. That is the problem here, isn't it? The heart has stopped, and so there is no blood going to the body's organs and tissues, and so we have to pump that heart until it's going to start again. And we're not just going to kind of do it as a bit, it's not always the coolest thing. We've got like a bag full of toys and stuff we want to get out and things that we want to do, but CPR is the absolute mainstay of treatment. So this is not kind of one-handed CPR while you're scruffling around in a bag trying to find something, or maybe not doing very good CPR while the pads are going on, or having multiple interruptions, particularly, you know, at the start when you've got so much to do, haven't you? This is focusing on doing really good, optimal CPR. And it's tricky, isn't it? So use some tools that you have. Use your feedback puck, put that on, and it'll tell you you're going too fast, you're going too slow, the person's getting tired, the depth is not good enough, you're not getting full chest recoil. So use the tools that you've got to feed back to you to make sure that you're doing absolutely spot-on CPR. And because it's really tough, I would suggest offloading it to a machine if you can. So if you've got access to a Lucas or another mechanical CPR device, then offload, that's a whole job, isn't it? That's one or two people's job has been offloaded. It's consistent rate, it's consistent depth, it even tells you when it's done 30, and you can kind of leave that job and know that it's been done well. Just make sure that you apply that device appropriately so that it's in the right place and it's actually delivering CPR and not a kind of stomach massage or something like that. But you use the tools that you've got available and deliver high-quality, optimal CPR. So you've got that going. You can start to work out what's going on now, can't you? So get a bit of history, have a look around you, what's going on in the environment, what other cues and clues have you got to tell you what's going on here? What is the major malfunction that has caused this patient to be in cardiac arrest? Is it a shockable rhythm? Is it non-shockable? Do you think it's primary cardiac? Do you think there's something else gone wrong with this patient? Start thinking about what the problem is. This is not a homogeneous group of patients that are cardiac arrest. There is something that has caused that patient to be in cardiac arrest. So for those patients who are in a shockable rhythm, we've got to get that shock in, haven't we? So we know that the things that help, high quality CPR and appropriate defibrillation. So we want to get the pads on and deliver a shock. And we only get to do this really every 2 minutes, don't we? And we know that for every minute that goes on that we haven't cardioverted that into a perfusing rhythm, the chances of that happening become less and less. We want to optimize those shocks, get them in at the appropriate time, and make sure that there's the best chance of that working. So how are we going to do that? Well, pad placement really matters, okay? And if you forget everything else I've said today, think about this, okay? You're going to try and sandwich the heart between the pads, okay? That is how you're going to deliver electricity. That's how you're going to get the current across the myocardium with the intention of cardioverting that shockable rhythm. So think about placing the heart between the pads. So we're going to start as normal with our anterior lateral pad position, but that is anterior lateral, okay? So it's anterior of the chest and right in at the axilla lateral. It's not clavicle spleen or humerus, iliac crest, or any of those other kind of things. We're going to get good pad position that sandwiches the heart between the pads. And if that doesn't work, we're going to move the pads, okay? Doing the same thing that hasn't worked and expecting it to suddenly work is not sensible. So we're going to move the pads. So think about when you're going to do this. It's all very well to look at a picture or to read JR count and go, oh yeah, we're going to do AP pad position. How do you do that? Have you all done it before? Have you practiced doing it? Have you thought about at what point you're going to do it? So you're going to wait till you've got enough people to move the patient, or do it when you're moving clothes, or do it when you put the Lucas backboard in. Like all of the things that you do, it needs to be planned and practiced and done thoughtfully and considered within the time that's going to optimize your shocks and reduce interruptions to CPR. Okay? So that's kind of the shockable side, okay? High quality CPR, effective defibrillation. But what about the other side of the algorithm? So I'm primarily talking about PEA here because in asystole, you might be starting to think, are we going to do the full 45 minutes? Is resuscitation appropriate? Using our information, what's happened here, what's going on? But in PEA, the heart wants to go. It might even still be going, it's just not quite enough that it's producing a palpable pulse. So PEA, you've got a heart that wants to go and something else that is the problem. So you're going to look and start searching for clues as to what's going on there. So it might be that you don't have enough circulating volume, so that you've had some losses. It might be some GI losses, it might be bleeding, it might be due to sepsis or some other distributive cause. You might not have enough volume. And these are the patients that we're still going to carry on giving IV fluids to. So we're no longer just getting access and putting a bag of fluids up, because that's kind of what we've always done. If you're giving fluids, you're giving fluids to treat a deficit, not just because it's a cardiac arrest treatment. So if your car had broken down, if it had run out of fuel, you put some more petrol in it and hope it would start. That's really sensible. If you thought the head gasket had blown, you wouldn't put in a can of unleaded and hope that it was going to start again. It's about thoughtfully looking for the problems that you think have happened and doing targeted, appropriate treatment and management to address those problems. So luckily, we've got a framework that can help us with this, because this is stressful, this kind of stuff, isn't it? You're doing some doing and you're doing some thinking at the same time. So we've got the 4 H's and the 4 T's. But this is not just a list that we recite: hypoxia, hypovolemia, hyperkalemia. We've all done that or thought that in a cardiac arrest. This is really thinking through this patient that I've got in front of me today. What is the major malfunction? So if you think it's hypoxia, if it's a hypoxic arrest, you need to optimize this patient's airway. So it's not just enough to go, I've got an eye gel in. Is it the right size eye gel? Does it fit well? Is it sealing properly? Am I able to do asynchronous CPR? Do I need to reposition the patient to optimize their airway? Do they need some gastric suctioning? Have I got enough oxygen left? Is it connected? Where's my next oxygen cylinder? All of these things that we're thinking about. Some of your history will help you. Rule some of these things in, rule some of them out. The patient that's just come on a long-haul flight and then became short of breath and suddenly collapsed, that's giving you some really good clues that it might be a thrombotic event. And also within this framework, you can think about what are the things that I could treat, what do I have a treatment for, and also, is there another way to get that treatment? So are there some things that are perhaps out with my scope of practice, but maybe I can get some help with? So be thinking here about, do I need to get some more help? Is there somebody else? Do I need to ask for one of the critical care team? Do I need a red team? Do I need basics responders? Is there somebody else in my area that can come and help me with these? So thoughtfully think about your 4 H's and 4 T's, and you'll also kind of within this, it's your sort of special circumstances. So do I have a patient, for example, who's pregnant, who I need to do some different things? I need to do some uterine displacement. I need to think about how will we access an emergency hysterotomy. So this thinking, I would argue, is the difference between basic life support and advanced life support. As clinicians, this is what we bring, not just an algorithm that we routinely work through. We bring some thought, we bring some decision-making, and we bring some deliberate and precise actions. So one of the things we need to kind of think about kind of early and then throughout the arrest, and I'm just going to sneak in another 1980s song lyric, is should I stay or should I go? Is this a patient that needs to go somewhere else for definitive care? Is there something that we've identified that this patient needs that is only deliverable within a hospital setting? And this might very much depend upon where you are or where the patient is, what's available, what's the geography, what means of transport you have available for you. It might not be the local hospital, so it might be that you have to think about some triage decisions. It might be, again, that you need something else. So is this a patient in whom you've actually got ROSC now, but is a little bit unstable and you need a bit more support? So again, thinking about colleagues in the yellow and red teams, if you can get them to help. So ask for that early. I think it's fair to say that most people would rather come and turn up and actually not be needed than be needed and turn up too late. So no problem at all for asking for that. But if you are going to transport, it needs to be done safely, and really you need to have mechanical CPR and people need to be strapped in. Your safety is really important too. And don't forget the critical care desk. So you might be somewhere where you can't get additional support physically, but think of this as a phone a friend service. So you've got lots and lots going on. Having another brain involved to help support you with some of this decision making, some really experienced clinicians who can perhaps just help you with running through some other things, maybe something you haven't quite thought about, something else that you can do to optimize this patient's physiology and increase your chances of getting ROSC. So phone them up. I hope that's fair to say. Some of the colleagues are here in the audience. So there's a lot going on, isn't there? It's busy, it's hard. So one of the things we want to do is think about team leadership. So as soon as you have enough people, you need to appoint a team leader. And I kind of like to think of it as the conductor of the orchestra. And this is tough to do when we're in a resource-limited environment, is to have somebody who's kind of standing back, standing off, because it's really difficult to be doing the doing and be doing the thinking at the same time, to be trying to deliver high-quality CPR and counting and ensuring you're doing a good rate and a good depth and you're not fatiguing and you're swapping providers whilst also going, okay, could this be hyperkalemia? So what we're going to do is separate some of that. And your team leader is not necessarily the most senior clinician on scene. That person might be doing a procedure that only they can do. And so the team leader can be a member of the team who is spot on at keeping track of your 2-minute intervals, making sure that shocks are being delivered, that the CPR providers aren't fatiguing, that you've given your drugs in the appropriate places, that they've kept notes of what happened, any changes in rhythm, and all of those kind of things. So there could be a scribe function built in there, but it's about the human factors of optimizing this team. And this conductor here, he's probably played this piece of music hundreds of times, but he's still going to have the sheet music in front of him, isn't he? So think about, have you got checklists? Have you got aid memoirs? Is it worth you getting the algorithm out and just being quite sort of didactic about running it and just thinking through, have we considered that? Have we optimized the airway? Have we given fluids if they're appropriate? Are there any other medications that we should be thinking about? And work through the checklist. Can we optimize our environment in any other ways? You might be outside and be thinking of the people that can help us. Do we need to move this patient? Do we need to do something so that their airway is better situated? We can deliver CPR better. But all of these musicians, they might not play together all of the time, but they do practice a lot. And I would say that a lot of the things that we talk about, we perhaps think, oh, we've been doing it a long time. I don't know, when was the last time I practiced CPR? We can do this, we can practice, we don't need high fidelity equipment and things like that. We can practice. How are we going to get those pads on? How are we going to get that posterior pad on? That's the kind of thing we can practice with some colleagues, isn't it? Put somebody on the floor, and how are we going to move that patient and do it when they've got clothes on and we're trying to do other things and deliver CPR? So we need to think, this is important work, but we don't necessarily do it every day. And so we should think about our opportunities to train and to practice in it. So just to finish up, I'm bringing you back to George and Andrew and WHAM, because what I want you to think about is, WHAM, what am I doing and why am I doing it? This is about being thoughtful, being considered, being the excellent clinicians that you are, and delivering high-quality CPR, appropriate rate, depth, minimal interruptions, good quality, appropriate, effective defibrillation, sandwiching the heart between the pads, and then looking for that major malfunction and providing targeted, thoughtful management and treatments. Leading that team so that you optimize the resources that you've got available, getting more help if you need it, sharing the decision making, with the goal of restarting that patient's heart, giving that patient the best chance of survival from cardiac arrest, and that's precision resuscitation. Thank you. No, that's fine.
Thank you so much, Els. That was such a clear and thoughtful presentation. Thank you so much. I'm used to thinking about the basic side of things, and so really great to hear just how advanced what happens out on the road is. And thank you to all of you who do that day in, day out. So we're moving on to our last speaker in this session. I can't see him. Oh, hi, Luke. Luke Roberts-Andrew is a clinical lead for the East England Ambulance Service and is focused on improving processes and systems in out-of-hospital resuscitation. And he's going to talk to us today about video triage. So I'm very interested to hear this one because it's related to my work that I didn't tell you anything about at the beginning. But I'm interested in increasing rates of CPR in out-of-hospital cardiac arrest. So over to you, Luke. Thank you.
Thank you so much. So I'm very good at a number of things, but timekeeping isn't one of them. So if someone could just wave when there's about 5 minutes left, that would be fantastic. So if it's okay, I'd like to start just with a short audio clip. This is a simulated 999 call. It's about 30 seconds long. I just want you to have a think about where this puts you if you're the person on the other end of the phone.
Listen carefully and I'll tell you how to do chest compressions. Make sure that he is flat on his back on the floor. Place the heel of your hand on the breastbone in the centre of the chest, right between the nipples. Put your other hand on top of that hand. Now pump the chest hard and fast, at least twice per second and 2 inches deep. Let the chest come all the way up between the pumps. We're going to do this until help can take over. Count out loud so I can count with you.
So I saw this week that 999 turns 90 years old next year. And listening to Andy talking about making a difference, the fact that we're having to explain this at the point of the call suggests that we've still got some way to go. But there's a lot in that conversation, isn't there? There's a lot of detail, a lot of things that are hard to understand, especially if you're in that situation of this being someone that you know, or even this being someone that you don't know, but you didn't expect. So there's a gentleman from Ireland, but studied or taught at the University of Glasgow, and he said that if you can't measure something, you can't improve it. And what I'd like to speak to you about for the next 18 or so minutes is something amazing that we've tried in the East of England, and we just really want to then understand how we learn from it and what the next steps are. So that call probably happens roughly around 10 to 15 times a day within your Scottish EOCs, just looking at your reports, and probably more than that, but just going off of the number of active resuscities that are reported. We've got very similar numbers in the East of England Ambulance Service, and we haven't seen a shift in the dial that you have despite some marginal gain work. So what we wanted to look at is how can we take something that's been audio with difficulty, with lots of barriers, and how can we use technology to start making a difference. So we've got these 3 handsome chaps at the bottom. So you've got Adam, who isn't here today. You've got Liam in the corner, who you'll hear from later, and you've got myself, who are the co-leads for this project. And I just want to thank Amaze and the NHS Charities Together and the East of England charity that supported us with something that had a lot more barriers than potential initially from some stakeholders, and allowed us to kind of give it a go and see what happened. So we launched something called the East Out-of-Hospital Cardiac Arrest Desk, and I'm not going to go into the details of the logistics and the boring bits of all the meetings that we had to go through. What I'd like to talk about is the impact on the patients. So we took 6 advanced paramedics in critical care that were already trained at doing dispatch. We spent some time with them alongside our colleagues, Louise, and we were really keen to get patient involvement right from the start. So we've got John there, who's one of our patient involvement leads, just to help us guide. And the aim for that was to make sure that the terminology, coming back to the evidence that you've kind of published and are working on, the terminology sits right, with the people that we're phoning and video calling. And actually there's some amazing, if you can grab Liam in the break, it'll be by the croissants, but if you just want to have a chat to him about some of the developments that we found using terminology like, I'm going to send you a video link so I can see through your eyes so we can work together until the ambulance arrives, so things that empower people. So we trained up our advanced paramedics, and just another thanks to Good Sam, the platform that we use for video triage was kindly donated for the pilot, and it allowed us to make, hopefully, a fairly significant difference to patients. So across that 6-month period for our pilot, we undertook 80 shifts. Now, these were staff that we already had in the organisation, but we don't have as many critical care paramedics embedded as you do within Scotland. So we had to beg, borrow and steal. So we didn't deliver as many shifts as we aimed to. But within those 80 shifts, they were quite busy. So that's a significant amount of calls to listen to. And when we look at the data, they're not just the cardiac arrest calls. Some of our falls were the ones that actually ended up with getting a critical care paramedic on early and using video triage to recognise that these were patients with abnormal breathing that were in cardiac arrest. Of those calls, 1,000 of them had a critical care paramedic on their cardiac arrest desk get involved, and that was either from an audio perspective, which is what most areas are already delivering and we were delivering before the pilot, but also, more excitingly, using video to get eyes onto scene, coming back to what Lord Kelvin said, to be able to see what we're doing so we can measure and change improvement. So I want to give you a case study, if that's all right, because coming back to Andy's point, we can talk about numbers, and numbers are good when you need a business case, but you're all here because of the patient. So we're going to talk about a patient. One of our first patients was a video call by one of our colleagues, Joe, that was on the desk. I think he just recently signed off, so this was one of his first shifts on his own. We had a phone call come through that Joe listened into early, and what we hear is a very distressed partner who is attempting to take instruction on CPR, but we can't really get that feedback as to whether it's working. So we hear the call handler, Hannah, who was counting 1, 2, 3, and we assume, or my assumption, is that CPR was going at that rate, but we don't know anything from a quality perspective, do we? If we look at what else is suggested good looks like, we don't know about the depth, we don't know about the rate, we don't know about the position. So what Joe did, and this isn't Joe, this is just James, not just James, get that out of the recording. What Joe did is got the video link sent through to the wife on scene, got her to click it, and just to hold the camera. And what we see, and I can't paint the picture and how emotive and amazing it is, but what we see is the son doing CPR, but he's only going on 3. Now, there's a massive assumption for me that when we count, people go on 1, 2, and 3. When you lift a patient, do you lift them 3 times? Or do we just lift them on 3? So there was some semantics there that we'd not really considered. The son of the patient that was doing CPR was neurodivergent, so we've had some conversations around actually do our instructions enable people from different communication strategies or different kind of neurodivergent approaches to taking information, and does that work for everyone? But what we also see is someone with the best intentions stood in a tripod position and in this standing pose over their father. They're doing CPR on the abdomen and they're only pressing on every 3rd count. So essentially we're doing a very slow rate in an ineffective area without very good recoil over the abdomen. What you hear for the next kind of 6 minutes before the crew arrive on scene is absolute finessed human factors of how communication is used with video to allow that patient, allow their son to move their hands up onto the chest, to move into a position where they can use their gross motor skill, gross motor muscles, and just maintain that ability to do CPR until the ambulance arrives. We see good recoil. We see the use of the metronome actually coming into that 1, 2, 3. And what we move to across that time before the ambulance arrives is really effective CPR. The ambulance arrives slightly later into the arrest. There's a significant amount of time that CPR was being delivered before we arrive. When the ambulance arrives, they go in, the monitor goes on, and we see VF. It's shocked twice, another 2 times, and then HEMS arrive. We have 2 more shocks, and then John regains a pulse. By the time John gets to PPCI, he's alert, he's awake, he's a little bit confused, and I think we can give him that, considering what he's gone through. John had 2 stents and he was discharged just under 2 weeks later back home into his family. So if we've got researchers in the room, what you'd probably say is anecdotes isn't anecdata, and we probably need some numbers despite it not being as fun. So across the 6 months, we counted 457 improvements to the quality of CPR that have been visualised through the desk. You can see the majority of those focus on hand position, on the arms actually being in a position that they can go in and out, but a number of other things, including defibrillator application. What we've seen in the limited number of cases where we use video, where there was a defib attached to the patient, is that in 60% of those, the defib pads need to be moved significantly. We know from our area that only 10% of our public access defibrillations are effective in terminating a shockable rhythm before the arrival of an ambulance. Now, is that because we're taking too long to get there? Or is that because the pads are in the wrong place? Or is it a combination of that and a lot of other variables? So what we also were able to achieve comes into what Shorty's going to talk about in a moment, and Andy and else kind of touched on around the appropriateness of resuscitation and recognising when we support someone that has died and we look after the family and we appropriately resource that with people that can support them versus throwing every single resource to that address and potentially causing some more psychological harm. So what we saw throughout that, we made a decision to kind of engage risk as much as possible and support our advanced paramedics to make decisions based on their experience, their knowledge, and what felt comfortable within their scope. We had amazing support from our medical director throughout, and we worked really closely with MPDS to make sure we were obviously doing it legally, but making sure we were doing it effectively as well. And throughout that, we saw a significant amount more of appropriate downgrades, recognising that patients were beyond help. But interestingly, what we also did, where they weren't sure, but they thought, and you've all been on those jobs, if you work in a clinical setting where you've gone to something and you read the CAD or you hear the notes and you think this probably isn't going to be viable. We empowered the clinicians to make those decisions, and they just left the nearest resource attached and stood everything else down. There's a risk that sits with that, isn't there? There's a risk that ALS might take a bit longer, but actually our preference is that we get someone there early to start BLS if needed, but recognising that actually these patients probably are beyond help. And what we found, for those that are looking for the financial benefit of this and why we should embed it in every single ambulance service, is a significant cost-saving and resource-saving impact. This is not what we put the desk together for, but this is an outcome of the desk, that actually a significant amount of our resources that would have gone to those addresses, that would have traipsed through that family home, that would have introduced their name over and over again to that member of family and not had that single point of contact. They didn't go to that job. They're available for the community to go to other things. We also introduced aftercare clinicians that contacted everyone that had consented for follow-up that had taken part in bystander feedback. And what I'd like to do with the last few minutes is play you a clip from Louise and her daughter. And the rough background, I won't go into the detail, but essentially they'd been out on a walk, mother and daughter, and they'd come across a patient that was face down. I'm going to play you a little bit around how they found the desk and what the impact was on them, if that's okay.
I think, and that's the biggest take from it, is it became a positive experience. One, because your sales phoned and checked up on us, but because these people enabled us to do whatever we were meant to do, we never left thinking, I didn't give that person the best chance. Yeah. We actually left thinking, you know, we did everything we could. We contacted people straight away, but we also then followed all those instructions. And so I think that is a big thing in that. And that is a positive in that we didn't leave them with sort of the mental difficulty of processing it. Obviously, it stuck in our minds, and I had the person's sort of face in my head for a long time, and I struggled to sort of walk for a bit, but I could then rationalise and think, no, but we did everything that we could have done. And so even when I realised that this person had probably passed, I didn't feel guilty and think, oh my gosh, could I have done more, or could I have approached it differently? Because I know that we got like the air ambulance there so quickly. I mean, there's sort of the helicopter, the ambulance was there, but we as soon as we were told to do something, we did it. And then because we got the counting, we knew we couldn't think, oh, maybe we didn't do that at the right pace or in the right place. It totally left us feeling, well, we did what we really could. And that is, I know it's about saving lives, but it's had quite an empowering effect on that. I've been able, we've been able to cope for it. We know that we did all we could.
Yeah.
So when we left, we just thought that was the normal. We thought that was the usual, and we didn't really give it much thought. And it was only when speaking to yourself that we learned it was a pilot. And that we just found shocking, because we know we wouldn't have been able to give the care that we did, or to feel confident in the care that we gave, or to cope with it afterwards. And it was so invaluable that we just instantly felt, well, we needed to do what we could to actually try and get this national, because other people deserve the same sort of like service.
So we've tried to engage with patients throughout this, and that theme runs through most of the, through most of the conversations of why isn't this national? Why is this new? Video technology has been out for a while, hasn't it? Especially with COVID, the amount that digitalisation just expanded to meet patient needs. So just in summary, we took an idea, we found some support for it, we got massive engagement from within our organisation. We don't have, we aren't at the point where we can demonstrate whether there's increased survival due to the retrospective nature of when we report our survival, but we are working on that. But coming back to Andy's point, it's not all about numbers. If we go back to John with the CPR going at quite a slow rate on the abdomen, having watched that video quite a few times, I feel comfortable saying that he may have survived if we hadn't done the video, but he wouldn't have walked home. He wouldn't have then been able to go back to his son and his wife and say thank you. So just in summary, if you've got an idea or there's something that you think you could shift the dial with, you're in an organisation that is a massive adopter of these things. And I think Scotland is in a really amazing place around cardiac arrest, and it's something to watch. But if anyone wants to know any more, go and grab Liam or myself in the break, and thank you very much.
Thank you, Luke. That was super exciting, and I'm sure lots of people will want to talk to you more about it. We've got time for one question before coffee. Yep. I'll just give you this mic.
I think this is a really exciting development. I was just wondering, in terms of like logistics, is this assuming that there's a second bystander to like video it, or is it the sole or the sole layperson like finding a position to put the video for the call handler to see it? And also, when you're sending out the video link, is that assuming like that there's service? Because like remote and rural areas, or even just in Edinburgh, when I leave my flat, there's so many dead zones that I have zero internet access.
There's two really good questions. So the first one, we started with risk awareness. So we just would only do it when 2 people are on scene, because we were petrified of making things worse. And what we did as part of this was regular catch-ups where we reviewed the cases with the clinician, and we explored the moral impact of that case as well as whether the process worked. And we really early, we were hearing from our clinicians that there were cases where they wanted to get involved, but they weren't because of the SOP that we'd put in place. And one of the examples was when there was only 1 person on scene. Because actually, if someone is doing an effective CPR, if we can take 10 seconds out for them to put a video link on, and then the next 7 minutes are optimized CPR, that was the decision that we made. And I'm not suggesting that was the right one, but that's the one that we felt was most beneficial. So about 2 months in, we made an adjustment and we included a lot more options. And essentially we empowered our clinicians, as long as they could rationalise why they felt that was the best time to get involved in the call, they were given that autonomy. The second question about signal, so if anyone's been to Norfolk, it's not as pretty as Scotland, but it has the Victorian telephone system. So there's just no signal at all. It is a barrier. You can't do any form of telecommunication if you don't have signal. We've measured throughout it barriers to undertaking video triage. Good Sam has worked really well for us. We've got a very small number of cases, and Liam will probably be able to go into the detail of the numbers, but I think it's around 6 cases where we've had intermittent signal, and then we've been able to send the link back through and it's worked. But it's definitely something to consider, and does that mean that our fleet of vehicles should have different kind of approaches to Wi-Fi for if we're going to use it for staff, and how do we work with the wider communities to make sure that there's not that inequality to accessing video triage in areas that might not have signal or might have things such as people that are on the other end of the phone with English as a non-first primary language, or people with learning disabilities that have phoned and we just need to communicate in an appropriate way. So there's still lots of questions there. Thank you.
Well, thank you so much.
Pleasure.
That was fantastic. And that applause is for everyone this morning. We've had 3 brilliant presentations to get us started. It's now time for coffee. I'm back in half an hour. Thank you.
If you can find your seats again, and we will start the next half of the morning that takes us up to lunch. Brilliant. Come and take a seat, and we will carry on with the rest of the morning. Hi, I am Vicky Joshi. For those of you that don't know me, I look after the Save a Life for Scotland Recovery Group. And I'll be talking a little bit this afternoon, but mainly I'm interested in you guys do all this amazing life-saving stuff, and then I'm interested in what happens afterwards. So as Andy was alluding to this morning, what life is like for survivors, family members, bystanders, but also for you guys after you've been involved in these events as well. We've got some brilliant presentations coming up this morning, including the Newton ward that will take us through to lunch. So I think the next speaker doesn't really need an introduction. I think many of you will know who this is. Mr. Stephen Short, if you would like to come forward, or Shorty, as he's better known. Shorty is the out-of-hospital cardiac arrest lead at Save a Life for Scotland, and is going to talk now about resuscitation decisions.
Thank you. Morning, everyone. How are we? Good. Yeah, good. So some brilliant speakers and me for the next 20 minutes. So, so I'm going to revisit something from a decade ago. Some of you might remember 10 years ago, this stage here, where we stood, and we had a great event, did lots of kind of cool stuff. And over that 10 years, quite a lot has happened. In fact, on that day 10 years ago was the day after the Brexit vote. And there was a fairly bizarre mood in the room. The NHS obviously became rich beyond its wildest dreams with £350 million a day. Oh, wait a minute, that never happened. We've had about half a dozen prime ministers, God knows how many elections for goodness knows what. And of course, we had the small matter of a global pandemic during that 10 years with all the absolute madness that came with that. Things like first name terms with Marcus and Leanne, DPD and Amazon respectively. Usually when they were delivering my wine delivery so I could get wrecked with my mates 3 nights a week over Zoom in the COVID arms, which was all very bizarre, really. But as Andy's already said, it had a massive impact on us in the cardiac arrest world. Right across the world, we all saw our outcomes plummet. And actually, this decision-making stuff played a large part of that as well. You'll know from inquiries that are ongoing, DNA CPR comes up a lot, and how decisions were made and talked about and all that kind of stuff. So COVID had a huge impact on us over these years. But actually, to be fair, I also jumped on this bandwagon and got a puppy. So it wasn't all bad news. And then Mrs. Clegg met Charlie, and Dr. Clegg found himself with a puppy as well. And I'm not sure he's fully recovered from that, if I'm honest. But actually, very deliberately 10 years ago on this stage, we wanted to talk about this stuff. And this was the title slide, because I didn't work for the ambulance service then, so it seemed less controversial. I was still in NHS Lothian, only just a resus officer, and I think that's important, because the stuff I'm talking about here today impacts hospitals as much as it does out of hospital. You can ignore that bottom bit, because I've left that cesspit of misery and doom as well, so you won't find that Twitter handle anywhere anymore unless someone else has nicked it. And that deliberate part of the conversation was all about trying to make us think about who we should and who we shouldn't be resuscitating. And we started with this kind of stuff. And some of you might remember this in GR Calc, this pretty arbitrary paragraph, really. And this was about it. Despite the fact we were trying to encourage all clinicians out there to think about the appropriateness of the resuscitation attempt they're providing, this was all you had. And you know, we did a lot of extra work. We were introducing 3RU at pace by now in the ambulance service, and quite a large chunk of 3RU training is about decision making. We introduced our advanced practitioners in critical care and actually learned a lot during the pandemic in terms of their support to clinicians out there for decision making, to cardiac arrests that we're actively responding to. And we still see that continuing today on the critical care desk. But perhaps most importantly, we should give a shout out to this team within SCAS. So Paul and Scott and Sandra, Kerry, Robbie, Caitlin, Tom and Amanda. I hope I've not missed any of them. But Amazing work. Honestly, this is my favourite work stream in the Scottish Ambulance Service by an absolute mile. The importance of this work is huge. And over the last probably 6 or 7 years now, the amount of effort and work they've put in with face-to-face sessions to talk about let's do the right stuff, and that involves decision-making at end of life and not subjecting people to treatment that's never going to work has been huge. However, the slightly depressing part of that story is it's not really had a single bit of impact on the number of people that we actively resuscitate as an ambulance service every year. So a lot of effort, a lot of enthusiasm to do stuff and do the right thing, but actually, in quite a crude measure, let's be honest about it, work to rest every year, it's effectively stayed exactly the same throughout that entire decade. And that's in the back of feedback coming to us all the time to say, we're in that living room, we know it's not the right thing to do, but we didn't feel like we could stop for various reasons. And I think our decision now is taking a slightly different path. So coming back to, I think it was your question, Ross, I'm sure it was your voice. What are some of the challenges? If you want my opinion about Scandinavia, they've got the denominator better. They're better at not resuscitating people who are not going to survive cardiac arrests. And I think there is a challenge with our denominators, not just out of hospital in the UK, but in hospitals as well. How often, for those of you that have come from a hospital background, have you been in that position around that hospital bed where you're thinking, what are we doing here? We've all been in that position. And difficult decision-making, difficult conversations. Conversations done badly, oh, you need to sign a DNA CPR form. What? No, you don't. What's that all about? You never need to sign a DNA CPR form. So, we're digging into this. We're trying to work out what's going on. This I'm about to show you is very, very provisional stuff. It is work ongoing, okay? But we've taken, oh, hello, work, there you go. We've taken 500 cases of cardiac arrests that were worked arrests where the person hasn't survived, and we've been analysing them. So this is our initial data. So this is nowhere near ready for publication yet. But of that, there's a pretty stark story in there, isn't there? So 40% of what ended up being 457 cases by the time you get rid of stuff. So far, about 40% of them have got markers for obvious futility or possible futility. Remember, these are people that have had a full resuscitation attempt, 40% of them. So talking about that denominator that probably feels like it's not right, the number of people we actively resuscitate, I think this is starting to give us a bit more evidence and data and understanding of why we're doing it. And the reason I say understanding is because when you dig into the actual free text on these things, almost universally when you're reading them, there's one word that jumps out to me. And that's confidence of clinicians to make these decisions on someone who you've never met before, on their living room floor, when you're surrounded by understandably incredibly distressed loved ones. And what do you do? And this isn't a new thing. This is a well-trodden path. So these are only 4 of probably the most recent papers published on this in a massive back catalogue in the literature that talks about decision-making, particularly in the out-of-hospital cardiac arrest environment. And actually, if you condense it all down, it probably fits into these 5 key messages. Most of these papers have some really interesting quotes in them, but there's one that stood out to me quite a lot, which says, doing CPR reduces my chance of being hit with a shitty stick. And I'm sure most ambulance clinicians in the room are familiar with that phrase. I can say with some confidence, if you don't do CPR and it's an appropriate thing to do within the Scottish Ambulance Service, and actually within any ambulance service in the UK, you won't get hit with it. But I think that risk asymmetry at the bottom, I think is an important part. So, what are we going to do about this? We've got lots of literature, we've got local evidence, we've got a long back catalogue of trying to make a difference, but not so far having made the difference, which brings us up to where we are in 2026 with the new termination of resuscitation in adults. So there's a few of us in the room today that have been involved with this stuff. And I think what you have here now is something we've not necessarily had before, which is evidence-based guidance on these decisions. So most of this work is based on the protected study, which isn't quite published yet. It's going through its final peer review, but we did have the principal investigator on the group with us writing this guidance. And it's been interesting introducing it, because we've had a lot of this feedback. It's not the headline, okay? Put this into real life. So when I get woken up at 3 in the morning when I'm on call for a decision support conversation with a crew, who you're usually met with, that's how I answer the phone at 3 in the morning, just for some of you might have been on the other end of that call. I can't think I've ever had a phone call where they've said, we've been resuscitating someone for about 25 minutes and we think we should stop. What I get almost all the time is, I've been resuscitating this person for an hour now. This is everything we've done, and we've run out of ideas, and there's nothing else I can do. I think in real life, in reality, work as done, not work as imagined, when we're understanding that this is the right kind of person to be resuscitating, we do it for a prolonged period of time. We probably just don't realise we are in most of those situations. Okay? And in fact, if you look at your JR-Cal cap and you dip into it and you look at those key points at the start of every single one, at no point in any of these key points can you see anything mentioned about 45 minutes. So it's been the headline, but it's not a key point to this guideline. The key point to this guideline is stuff about best interest decisions and futility and chances of ROSC and will it work and all that kind of stuff. So let's put it into reality, and some of you will remember Bert, because you've met Bert before. So Bert was a legend. He was my wife's granddad. Died when he was 96. Haven't had a great life. He was born in Wales. Used to make me drink Penderyn whiskey. Oh, should come with Gaviscon as a mixer. But you had to say yes. Spent most of his adult life in Kelso in the Borders, where he met his wife, but was widowed quite young, and for the last 20 years of his life, spent it down in Luke and Liam's neck of the woods in east of England, actually shacked up with his girlfriend, the dirty old dog. And Bert died at home, an amazing death. You know, he'd had a great life, but suddenly heart failure caught up with him when he was old, and it progressed quickly, and he died peacefully in his house. He had lots of input from East of England Ambulance Service, actually, who would, before just in case meds being used by ambulance service were really a thing, was getting all the kind of right stuff. I think, unfortunately, we end up at Bert in crisis too often, and sometimes it doesn't go right, because we need to decide where we're going with Bert when we get there. Are we going full-on Elves freshwater, funky-haired wham with Bert, having taken him off his hospital bed in the living room, probably found by their carer, and still continue to do now 45 minutes of resuscitation? Or actually, are we going to spend a bit of time thinking about those key points within the guidance that's available to us to try and avoid putting Bert through the probably less desirable thing that's happening right now? So if we look at some of these key points, sounds really easy, doesn't it? We need to aim to differentiate between patients who've died and those where there's a chance to restore life. When you've just driven there quickly, you've never met the person before, you've got no idea what the house looks like when you're walking into it, let alone what you're going to see when you get there, and you're trying to take on all this information. Do you even notice there's a bed in the living room, let alone it's a hospital bed, or the just-in-case meds that are lying in the corner that the family have lost the ability to tell you about because they're so upset and distressed at this point? It's really difficult. However, there is stuff within this guidance that's there to help you. And it talks about, you know, consider all the different factors. I'm not sure what the difference between frailty and advanced frailty is, but anyway, likelihood of ROSC. What are their wishes? You know, a patient's known and expressed wish is a really valuable tool for us as clinicians in this situation when we're putting all these little bits and pieces together so that we can try and make that decision in the best interest of Bert and others like him. Because we understand that actually a lot of these conditions are incompatible with life. And so for those conditions and for those patients, the right thing to do probably isn't 45 minutes of life support. There is a really helpful caveat within all this as well, though, is sometimes we just don't know. And I think an important message to get over is 45 minutes isn't a definite time. You don't have to follow 45. You don't watch that clock timing you because you want to get that defib switched off. You do 45 minutes as a minimum when it's appropriate to resuscitate someone. If it's not appropriate, and that becomes clear during the resuscitation attempt, even when you're at the point of advanced interventions, if it's obvious it's not going to be appropriate, off ramp from what you're doing and stop the resuscitation attempt earlier than that. All of that's there to help you and support you to choose the right path, full-on resuscitation, not to resuscitate or to stop resuscitation earlier because it's not the right thing to do. So there's some key points within it. It's not about 45 minutes anymore. Ignore the time, okay? The time's only appropriate when it's appropriate that you're resuscitating someone properly. Have they died, or as Elle said, they're trying to be alive? One of the big decisions. And is what you're doing in the best interest of that patient? Is that patient going to go to hospital, going to go to critical care, go through that challenging journey for them, and come out the other side of that to be able to function as close to they were before they had their cardiac arrest? Is that something we can achieve for this person? And if it's not, the right thing to do is to stop. And I want to finish by flipping this slightly today. I don't necessarily want you to ask me questions, although you're very welcome to at any point today. I want to ask you a question. And I don't want the answer to it just now. I want you to think about it and reflect on it, and then I do want you to answer it. Because we want to know, organisationally, not just in SCAS, but right across the NHS, not just in Scotland, but the whole UK, what can we do mostly to increase your confidence, to help you with this decision-making in a really difficult point in a patient's care? And I'm going to stop there and say thank you for listening to me.
Thank you, Shorty, for a really thought-provoking talk there. Unfortunately, we don't have time for any questions, but I am sure Shorty would love to be caught by everybody before he gets anywhere near the food at lunch.
Thank you.
I'd be very happy to answer your questions at that stage. Thank you so much.
No worries.
Okay, next to the stage, I would like to welcome Professor Andy Baker. Andy is a British Heart Foundation Chair of Translational Cardiovascular Sciences, and he's going to talk to us now about hypoxic, blackout, and out-of-hospital cardiac arrest.
Thank you very much and for the invitation. And I'm definitely a resuscitation meeting virgin. I don't really know anything about resuscitation, but I'll tell you a story that brings some messages, but also tells you a little bit about physiology. This is kind of a little bit of a personal journey. It has nothing to do with my day job. I work down at Little France, a couple of miles from here. I'm a discovery scientist, so I try and find discoveries and put them into help cardiovascular patients. But this is my son George and my daughter Serena. And I'll tell you a little bit about shallow water blackout, which I knew absolutely zilch about until about 2 or 3 years ago. So I was really privileged in the end. This is published at the tail end of last year. It's a collaboration between myself, Hugh Montgomery from UCL, Mike Tipton from Portsmouth University, Joe Talbot, Royal Lifesaving Society, RNLI, Swim England, etc., to try and bring together a few things from a fragmented guidance and fragmented information into a single document that talks about lived stories. I think they're really important, and that's where I come in, to understand the physics and physiology of what happens with a hypoxic blackout, and then guidance around prevention, which seems to be the key thing, as well as rescue, resuscitation, etc., and treatment. But the only way, I've only got one way of telling the story, and that's exactly how it happened. So I've got a privilege. I've got 5 kids. I always say 3 biologically, 5 legally. 3 from my first marriage. They're all grown up, George, Serena, and an elder sister, Olivia. I'm remarried. My wife is Dutch. So like the rest of the Netherlands, you don't fly on holiday. When you go on holiday, you drive south. There's a mass exodus with caravans, etc. So we do that. And I always try and entice my kids to come, and they always say, well, where are you going, before they make a decision. And so we always try and find somewhere nice. And this place is near Montpellier, called Gradois. We've been there before, and it's a cool place. It's really nice. And they have this centerpiece of this pool. which is about 40 meters in length. This is just a picture from the website. So there are 4 of us there. My eldest daughter's a doctor. She didn't have time to come, but my Serena was a medical student at the time, and George at university. They had plenty of time in the summer to come and enjoy time with us. So this is a pool. In there is my non-biological son. This is Jasper, my daughter Serena, my wife. This is just really great. We had a GoPro doing lots of underwater stuff and enjoying the time. In the pool, just a disclaimer, it does say at the sign at the entrance, there's no life-saving guard, no lifeguard, which is fine and obviously quite common at the time. So what actually happened halfway through the holiday, this is just a little scenario planning I did, which is exactly the way it happened. People in black are people just chilling in the pool. It's just after lunch. George and I being very competitive with each other and elsewhere, and all my friends and family, you're a bit competitive in the pool, right? How far can you go underwater? Serena is just chilling at the side in green, listening to music, falling asleep. And George and I basically do, how far can we swim underwater? It's 40 meters, so quite a length, so we thought we'll try it. So we did 3 attempts. We went exactly 25 meters, so to about here. And then we went back pretty quickly, tried again, 25 meters, went back again pretty quickly, 25 meters. So after 3 attempts, I got a bit bored, and I thought I'd get out. So I sat next to Serena, and then George, being pretty competitive, saying he wants to beat his record and wants to beat me, basically, rather than beat himself. So he went back, he did a 4th attempt, 25 meters. And this time, he said, I'm going to go 1 more time. So he went back, and he started hyperventilating this time. So he did his breathing exercises. So just rewind, 2 years before that, I've been on another holiday, and all 3 of my kids came that time, which was great. And also the now husband of my eldest daughter came as well. So he was doing this weird thing in the pool in the villa where he would do a bit of a warm version of the Wim Hof method. So he would hyperventilate and submerge. So he did that, and he was down in the pool at the bottom of the pool for about 10 minutes. So I thought this was really a bit weird. But George also started doing it during the course of the holiday. And he'd be down there for 5 or 6 minutes. I thought it was a bit weird, but I didn't want to interfere. Anyway, he was doing the same sort of principle here on his final attempt. And essentially then, he launched himself, and he went about 30, 35 meters. And then I'm watching, thankfully, I'm watching him at the side, okay, trying to sort of egg him on and hopefully beat his time. And I saw, because I'm next to Serena here, and he's gone that way, I saw the back of his head come out of the water, and I thought, he's got oxygen, he's going to go back down again and get to the end of the pool. But he didn't. So he went back down again, and in hindsight, retrospectively, his mouth hadn't come and got any oxygen. He went back down, and he's just started meandering around and then just stopped. So thankfully I was watching, so that sort of alarm bells, and then so a bit freaked out, of course. I went into the pool, and basically, a bit like the movies, when I got there, he was lying, facing up, eyes open, completely motionless. I don't remember, so we're right at the edge of the pool here at the top. I don't remember actually getting him out at all. I'm not a strong guy. But I got him out in a single, in a oneer. I had 2 really crap hips at the time, and for me to get out of the pool, I could never do it, but I leaped out of the pool after him. So this was all very quick. At that point, I thought, shit, I never did CPR training. So that had that thought very quickly. But I did check, he had no pulse, he was blue, and he definitely wasn't breathing, his heart had stopped. So I went straight to chest compressions. I did that. Thankfully, my daughter, who was listening to stuff on her iPod, actually, almost asleep, she had sensed something was happening. She had CPR training as part of her medical degree. She was 5th year student at the time. So she launched herself around the edge of the pool. She shouted to get emergency services to someone who, because there's a restaurant there, she came round. And then she checked his airways, put his chin back, and started CPR with, and we alternated a little bit with the chest compressions, but still nothing happened for a couple of minutes. So I think it was about 4 minutes or so he hadn't basically had any oxygen. At that point, some water did come out of his mouth. He started to come round. I've never experienced anyone in this situation at all, and then he came round, and then immediately, for the next couple of minutes, it was obvious he was completely brain dead. I mean, he was just one eye that way, and making some horrible growling noises. A nurse who had been walking past had come by, kept him calm, and my daughter sort of spooned him to keep him calm. And he did start to come around very quickly. So within, I don't know, 5-minute period, he'd gone from essentially dead to brain dead to actually coherent. And by 10 minutes, when emergency services finally arrived, he did know who he was. He did know his name. He did know who I was and his date of birth and all that sort of stuff. So he made a pretty quick recovery, which was great. So they blue lighted him to Nîmes. He spent 4 days in a cardiology ward. They were brilliant. They did every test under the sun, no cardiac abnormalities whatsoever. When he came back to Scotland, the team in Glasgow also checked him out, genetic tests, and nothing at all. So this was a bit of a mystery why it happened. So we went down at BHF. I'm a BHF professor, not being CPR trained, bad message. My bad, completely quite open about saying that. I mean, I thought about it for 40 years, but never did it. It was really, really sad. Everyone I've told this story to who's not been CPR trained is now CPR trained. My whole lab and everyone associated with that. So we did help the BHF. I'm not sure the conflict between cushions and mannequins and stuff, but BHF have this Reviver app. So George and I helped launch that in Scotland. All schools were getting this training or something, but they did it at Craigmont School, which is quite close to here. And they did that because there's a guy called Brodie, a bit like the first talk, he'd saved his dad's life. He's a pupil at the school. He'd been given CPR training by his teacher, not part of the curriculum, just on a sort of an afternoon where the teacher thought that'd be a great idea, and saved his dad's life when he had a heart attack at home. So that's a really nice story. So we helped to launch that. But what had really happened to George, we didn't really understand that. So as a scientist, I really wanted to kind of understand that. So the worst thing I did is went to Google to tell me. But actually, there's this website. It's in the US, and they're very organized. And they have this cartoon here, which is exactly what happened to George. So hyperventilating, that changes your blood gases. That makes you, this is a danger signal for your blood gas balance when you're underwater, and the conflict between oxygen and your drive to breathe. And it's really clear, and Michael Phelps Foundation and everyone's involved in this, but everyone I had spoken to, hundreds of people, were quite well connected professionally, no one had ever heard of this. So a cardiologist friend of mine said, well, this guy Hugh Montgomery at UCL, I think something happened to his son. So I got in contact with Hugh, we had a chat at the welcome, and it's really, we had a near tragedy, but this is a real tragedy. And very similar physiology. So his son Oscar and Hugh, they'd always been in the water, so they would hyperventilate at the surface, they would free dive, spearfishing, that sort of stuff. They always did it together. At the end of the pandemic, Hugh wasn't available, so Oscar went on his own and essentially died. So he had a hypoxic blackout, submerged about 10 meters. His body washed up about 3 weeks later. They saw the GoPro with his watch, etc. So this is a real tragedy, but it's the same concept about this conflict between your blood gases. So we decided we should do something about this. We spoke to Mike Tipton at Portsmouth, who brought all this together. He's works in the extreme environment, so he's a complete expert in all of this. And we came up with this publication that I showed you earlier to try and at least bring something back in terms of guidance in the same place. Because as I said, nobody I knew had ever heard of this, and many professionals. So we had this as lots of guidance. Anyone, including young, fit, usually males, because they're ultra competitive, at least in swimming pools, young males, a bit like the car driving stuff, isn't it? They're the most prone, highest insurance. Can lose consciousness underwater. Education, supervision will reduce the risk. Guidance is essential. Hyperventilation seems to be a key thing. There are, of course, dangers in the water anyway, but the hyperventilation seems to be a common denominator. So we came out with this, and if you're interested, read it. It's quite nice. The physiology, just very briefly, if you're swimming in the water, underwater, without hyperventilation, as you go through, you lose, you're consuming oxygen, of course, with your muscles as you're swimming. Your CO2 up, which drives your drive to breathe, comes up, and then naturally you come up for a breath. But if you override that, and some people, because they're so competitive, will, or coaches for professional swimmers or semi-professional swimmers doing these lung busters, where you just go underwater as far as you can, you repeat it, that just heightens that, and coaches completely ignore it. Secondly, if you're trying to, like George did, exactly as George did, when you're trying to beat your time, you basically have to, you lower your CO2, and that means that your drive to breathe, the threshold isn't reached early enough before your oxygen depletes, and you become unconscious. And this is very real. It gets a bit more complicated with the diving because you've got pressure from the water, but essentially, again, if you hyperventilate at the surface, this picture at the surface, you lower your CO2. As you descend, when your alveoli constrict, that elevates your CO2 and your oxygen in your blood. If you stay down there during your breath hold, this reduces, but probably not enough for the CO2 to get your drive to breathe. And so this is the danger point. And of course, when you, as well known, when you dive and you go back up and your alveoli relax again, you can have a rapid loss of oxygen. And this is particularly what happened to Oscar. And very finally, this is quite important implications. This was a case last year, actually, a kid in Northern Ireland who was a very sort of semi-professional swimmer. He was going up and down the water, underwater, and at the end of that, he submerged, and that was what he did normally, and just stayed down under the water for a little bit. 3 lifeguards on duty, they all thought that was normal. That was his normal practice. But he stayed down there, and he died. And they tried to sue the lifeguards, but it wasn't part of their training. That's what he'd normally done. So this does kill people. What I think is important is guidance. When you go to a swimming pool, everybody knows before they go into a swimming pool, don't dive into the shallow end, right? Don't be a muppet. You're going to bang your head. And there's guidance when you go into the swimming pool that says, don't dive in, you're going to bang your head. But there's nothing in any swimming pool in the UK about breath holds. Okay, nothing at all. So that is the task at the moment, is to improve the guidance around that. I just made this for RLSS when I gave a talk there recently. All you need is some signage. This was created in 30 seconds by Google Gemini. So just a little bit of awareness about don't do extended breath holds, don't hyperventilate. If you're going to do it, somebody needs to know about it, and you need a buddy. So after all of this, the still points are hypoxic blackout is pretty rare. Not that many people drown in the UK every year, but it's way too many. Every single one is preventable. But it's devastating. Most people who have a hypoxic blackout die. The numbers are around 90%. And a lot of that is in the US and places where you have a pool in the back garden and you're swimming on your own. So the majority of people die. Outside the swimming community, no one's got a clue about any of this, any of the physiology, any of the danger. So we need to up that guidance because it's entirely preventable. And that's the story. And I did do formal CPR training after that. Thank you for listening to me. Anyway.
Andy, what an amazing presentation, and thank you so much for sharing your story and presenting this all so clearly. I have to say it's not something that I knew about, and I'm now looking back
do
on
now.
our family holidays, and we did exactly the same thing. So, yeah, I think it's both super interesting, but also incredibly useful, and a message that probably needs spreading as well, by the sounds of it.
Thank you.
Thank you so much. Okay, our next presenter is a little bit like Shorty, probably needs no introduction to this audience. I'd like to welcome Lisa McInnes to the stage. So Lisa is the lead research nurse for the Resuscitation Research Group and also works very closely with SOUS and is very well known to SCAS, and is now going to lead the session for the Newton Award.
Thank you so much. It's so lovely to be here, and this is I will say this is my favourite part of SCAS, apart from all the fabulous talks. But how do you follow that last presentation? Such a personal story, and it's that kind of stuff that really, I guess, hits hard and hits our hearts most round about out of hospital cardiac arrest. And that's why I think it's perfect that the next people to invite up are Gregor and Judy Newton. So I'd like to invite them up to the stage. Give them a welcoming clap. Oh, have we got a microphone? I want to hear any microphones that Gregor or Judy could use. Oh, thank you so much. Here's one. The Newton Award is something that's been running for a while, and I'm going to start by just asking Gregor and Judy if they would just explain really what it's all about and what you guys can expect from this next section.
Good morning, everybody. What a morning so far. The education and information that's been shared by all the speakers is just truly inspiring. And, you know, it never ceases to amaze me the amount of, you know, the information and the wanting to learn and the appetite that you all have to learn, get better, be better educated and make improvements from us as survivors is truly inspiring. And that's really what the Newton Award is about. It's about recognising outstanding achievement just now in Scotland, throughout Scotland, when any part of length and breadth of the country. And it's mainly because if it wasn't for people like you, there wouldn't be people like us. You know, and we're indebted from the bottom of our hearts of what you all do in your communities and any job that you're in, from whatever situation it is and what role you have, because it is unbelievable to be in the position that we were in and have total strangers that came and, you know, helped with CPR and got the defib and the first responder that was there, people that I've never met. And it was just still 12 years later, truly humbling that I walked past a normal guy who was the first responder on the day, and he just gives you a wee nod and a wink on the way past because he knows he made a difference to us. So that's what the Newton Award is. It's recognising the outstanding achievement that you all do in your communities day to day over the last year. Thank you.
I mean, if you want to sing us a song, you're more than welcome, but no, we don't want to hear that, okay? I can't imagine a world without Gregor and Judy in it, so yeah, absolutely, I completely echo them. Just what we want to do at this point is recognise people who are making outstanding differences in their communities across Scotland. And these are just nominations that people have written. I know that there's so many other people out there who are just chipping away every day and saving more lives. I don't know if you've ever written a nomination. They're quite tricky. So I really respect that people have put time and effort into writing their nomination. So if it's okay with you, as we go through these nominations, I'm just going to read out what people have written and have a good listen just about the real variety of nominations that we've had. I don't know exactly who's in the room, so what I'm going to do is read the nomination, and if you're here, I'd like you to, after I've read it, come up and receive your nomination certificate from Gregor and Judy, and then just return to your seat. So let's get started. The first person that we have is Amanda Baird. Amanda is the Deputy Head of Service Delivery at Chest, Heart and Stroke Scotland. And since Chest, Heart and Stroke Scotland launched the out-of-hospital cardiac arrest bystander support service in November 2023, more than 130 people have received compassionate support after experiencing one of the most traumatic events imaginable. Amanda has been the driving force behind this service, shaping its vision, building its processes, and ensuring that bystanders, so often overlooked, are never left without help. Her leadership has been instrumental in establishing a strong, responsive aftercare pathway, and Amanda has equipped and empowered the Chest, Heart and Stroke Advice Line team, who now deliver high-quality, person-centred support every day. Their work reflects her commitment to empathy, safety, and dignity for all who reach out. Recently, Amanda witnessed an out-of-hospital cardiac arrest herself and delivered CPR. And this deeply personal experience has further strengthened her insight and passion for post-cardiac arrest care, reinforcing the importance of the service that she helped to create. Through her compassion, determination, and guidance, Amanda has transformed an innovative idea into a vital lifeline for those affected by cardiac arrest. Her impact is profound, her leadership inspiring, and her contribution truly deserving of recognition through the Newton Award. Now, I don't know if Amanda's here. She's not here. Who said that? Oh, you could come up, come up. Let's give her a big clap. Please pass on our big hugs and thanks to her, because she sounds like an absolute superstar. Okay, next up, Pierre Ellis, who's a paramedic with Edinburgh MacDonald Road Ambulance Station. Pierre identified a long-standing gap in structured, regular training for 3RU team members, a group routinely exposed to and tasked to lead out-of-hospital cardiac arrests. Recognising the risk this posed to clinical readiness, he took personal responsibility for addressing it. He's led the development and delivery of regular 3RU CPD sessions in Edinburgh. Working in his own time, Pierre designed practical, scenario-based training focused on contemporary challenges in cardiac arrest management. The impact of Pierre's contribution is significant. These sessions provide a rare opportunity for paramedics to rehearse cardiac arrest management, refine technical skills, and strengthen non-technical skills such as leadership and team coordination under pressure. As a result, clinicians are more confident, consistent, and better prepared to manage critically unwell patients. Pierre's work extends beyond education. By strengthening the capability of multiple clinicians, he directly supports improved patient outcomes and the wider chain of survival. His sustained, self-directed effort demonstrates a clear commitment to improving care across the system, making him highly deserving of recognition through the Newton Award. I don't know if we have Pierre with us. He's maybe out saving lives while the rest of us are having a free lunch. He's not here. Can we give Pierre a big clap? Is somebody willing to come and grab his certificate for him? If anybody, does anybody? We'll give you a big clap as well. Thank you so much. Oh, brilliant. We'll give him a big pat on the back. Okay. So next up, we've got something slightly different. So we have the University of Edinburgh Saving Lives student group. Over the past 3 years, the Saving Lives student group has trained nearly 2,000 people across Edinburgh in life-saving skills. This dedicated group of nursing and medical students has built a strong interprofessional initiative, recruiting volunteer healthcare students to deliver CPR training. What began as a university-focused initiative has grown into a far-reaching community programme. Over the past year, the group has expanded into sports venues, schools, mosques, and community centres, with particular focus on reaching socio-economically deprived areas where such training is most impactful. Group has also engaged with political organisations, attending the Scottish Parliament, and secured funding to sustain and expand their work, all while managing the demands of their studies and clinical placements. Their commitment to community engagement, reducing inequality, and delivering high-quality education is commendable. The professionalism and ambition demonstrated by these students is inspiring, and their achievements make them truly worthy of recognition through the Newton Award. Now, I know we have some of them here today. I don't know if somebody wants to come up, or all of you can come up and grab your certificate. When you come, give them a big clap. It's always good to get your picture taken. It's nice for your CV. Excellent. Okay, so next up we have Stephen Byers. Stephen is a community first responder through Neilston and Uplaw Muir. He's been a founding member of the group and has dedicated years of service to his community, both as a responder and coordinator. He regularly volunteers his time, responding to emergencies through both the official responder role and the Good Sam app. As coordinator for over 12 years, Stephen has played a central role in organising volunteers, leading fundraising efforts for defibrillators, and ensuring the sustainability of the group. His leadership has had a significant impact on response capability in a rural area where ambulance arrival times can be prolonged. Stephen is deeply committed to community resilience. He delivers public training sessions, organises awareness events, and works with schools and community groups to increase understanding of CPR and defibrillator use. His dedication, leadership, and passion for improving outcomes in his community have made a lasting difference. And Stephen's continued commitment makes him an outstanding candidate for the Newton Award. Is Stephen in the room? Oh, here he comes. Put that one in the local paper. Okay, next we've got David O'Neill. I'm going to keep drinking my water because there's a lot of reading in these nominees, right? David is a technician and community cardiac responder with the Vale of Leven ambulance service. He's a full-time ambulance technician whose dedication to improving outcomes from cardiac arrest extends far beyond his professional role. As a community cardiac responder, he regularly attends incidents in his own time, having responded to over 60 cardiac arrests off-duty. His commitment is both consistent and selfless. He sacrifices personal time to deliver early CPR and defibrillation, strengthening the chain of survival and improving patient outcomes. He also supports on-scene crews by assisting with equipment, preparation, and post-instant duties. On one occasion, following a successful resuscitation, David drove a response vehicle to hospital in his own time, allowing the attending paramedic to remain with the patient, committing over 3.5 hours of unpaid support. David acts without expectation of recognition, demonstrating exceptional professionalism, compassion, and commitment. His contribution to patient care and community response makes him highly deserving of the Newton Award. Do we have David? Everybody's going to want David with them now if he does all the tidying up and sorting out his stuff after response. Thank you, David. Okay, next up we have Arif Sadiq. However, I know him as Harry, so I'm going to call him Harry if that's okay. Harry has dedicated many years to delivering CPR, AED training, first aid and health awareness workshops across Scotland, alongside his role as a paramedic. He provides this work voluntarily, extending his impact far beyond his professional duties. His focus on engaging ethnic minority communities and those in deprived areas has helped reach individuals who may not otherwise access such training. Through his efforts, Harry has built strong connections across diverse communities, promoting health awareness and life-saving skills. He is widely respected for his passion, inclusivity, and commitment. Despite high demand for his work, he consistently makes time to support communities and deliver training. His ability to bring people together, empower communities, and improve access to life-saving education makes him an exceptional candidate for the Newton Award. Harry. There you are. So get him at lunchtime. Get his number in your little black book. He's a very handy contact to have. Okay, next up, Liam Neal. Liam is group coordinator in Aberdeen, West Hill and Kingswells. Following the loss of his father, a paramedic of 43 years, Liam continued to lead and develop his community first responder group with resilience and determination. During a deeply difficult time, he ensured the continuity of training, operational readiness, and community support. He has worked tirelessly to organise defibrillator awareness sessions, community training, and fundraising efforts to provide vital equipment. His work has directly contributed to lives being saved within the community. Despite personal challenges, Liam has remained on the front line, supporting both his team and the wider community. His strength, leadership, and dedication make him a truly inspiring figure and a deserving nominee for the Newton Award. Now, do we have Liam? I know Aberdeen's quite far away. Oh, here he comes. Hi, Liam. Brilliant, thank you. So from Aberdeen to the Isle of Arran, we've got Fiona Lane. Fiona has been the driving force behind first response services on the Isle of Arran for over 20 years. Her leadership, dedication, and organisational skills have ensured the sustainability and effectiveness of the local responder network. She inspires and supports volunteers, provides ongoing training, and recruits new members to maintain service provision. Her commitment has enabled periods of continuous 24/7 coverage in remote areas where emergency response is critical. Fiona is widely recognised as the backbone of the service, always available to provide guidance, encouragement, and expertise. Her unwavering commitment, knowledge, and enthusiasm make her an outstanding and deserving candidate for the Newton Award. I don't know if we've got Fiona. Aaron's a bit of a trek. Anybody know Fiona? Come on up. Thank you.
She is watching online. So
Oh, well done. I was going to say, Fiona, we can't take you off the Isle of Arran. You're obviously doing far too much good stuff there. So you just stay put and you keep watching. Get a new cup of tea in a minute. Okay, so next up we have Wilma Pert. Wilma is from Broch Community First Responders in Fraserburgh. Wilma has demonstrated exceptional dedication to her community. Through her work as a volunteer community first responder, she's devoted significant personal time to responding to emergencies and supporting patients in need. Known and respected across the community and by ambulance crews, Wilma consistently goes above and beyond expectations. She has attended hundreds of emergency calls, often working late into the night and across weekends alongside her day job. Her commitment, reliability, and impact on patient care and community resilience are considerable. Wilma's efforts have saved lives and strengthened emergency response in her area, making her highly deserving of recognition through the Newton Award. Now, the Broch is even further away. Is Wilma here? Anybody who's from the Broch? Right, we're going to have to put that one in the post. Let's give her a big clap anyway. Thank you, Wilma, for all that you do. Next up is DH9 Foundation, so an organisation. The DH9 Foundation was established in memory of David Hill, who died from an undiagnosed heart condition at the age of 30. Since its creation, the foundation has worked tirelessly to raise awareness and funding for cardiac screening among young people. They've raised over £100,000 and facilitated the installation of defibrillators in numerous schools, as well as delivering CPR training across the communities. Their work also includes educational initiatives aligned with the Curriculum for Excellence and the development of tools to track training provision. The Foundation has contributed to policy discussions and helped shape national approaches to preventing sudden cardiac death in young people. Their impact in a short time has been remarkable, making them highly deserving of recognition through the Newton Award. Do we have anyone from DH9 here today? There we go. On you come. Thank you. Again, grab these people at lunchtime. They've done an amazing amount of work in such a short space of time down in Dumfries. Okay, Frank Rooney is up next. He's a community first responder in Airdrie, and he plays a key leadership role within his group, mentoring, coaching, and supporting fellow responders. He has attended over 110 incidents since November 2025, demonstrating exceptional commitment and reliability. Despite facing complex personal circumstances, Frank has remained dedicated to his work, consistently supporting his group and community. His passion is deeply rooted in personal experience, driving his commitment to improving outcomes for others. Frank's leadership, resilience, and tireless dedication make him an outstanding candidate for the Newton Award. Do we have Frank? Thank you, Frank. So Airdrie seems like a busy place with 110 since 2025. Thank you for all that you do, Frank. Okay, almost there. Colin McDougall is up next from the Isle of Ona. We're certainly getting round the islands today. Colin demonstrated exceptional awareness and decisive action when he recognised that an individual had gone into cardiac arrest in a remote location. With ambulance services over an hour away, he immediately initiated CPR and coordinated access to a community defibrillator. He delivered 2 shocks, resulting in a return of spontaneous circulation, and the patient made a full recovery and returned home. Colin's actions are a powerful example of the life-saving impact of community CPR and defibrillator access. His swift response and composure under pressure make him highly deserving of recognition through the Newton Award. I don't know if we've got Colin. It's a bit of a trek on that ferry. Anybody from Iona? Anybody want to go to Iona? We'll pop that one in the post and give him a big clap anyway. Thank you, Colin. And finally, we have Craig Snedden. Craig is a community first responder from North Berwick. Craig has been the sole community first responder in the North Berwick area since the COVID-19 pandemic, providing vital emergency response cover. In addition to responding to life-threatening incidents, he leads CPR and defibrillator training across the community, delivering multiple structured sessions and supporting the recruitment and development of new responders. He has established local training initiatives and contributed to building a sustainable responder network in the region. His dedication to both emergency response and community education has made a significant impact. Craig's commitment, leadership and initiative make him a highly deserving nominee of the Newton Award. Do we have Craig with us today? Here he comes. Thank you, Craig. Craig comes from my neck of the woods, and every time I see him, I know that he's going to get me to fill out that community first responder form. I can just feel it coming. Thank you for listening to all those nominations. I know it's a lot to listen through, but I think it's a really good, diverse group. It's lovely to see people in our services being recognised, people who volunteer their own time, groups that have taken initiatives, people in the community who just want to make that difference. So I encourage you, when we put out for the Newton Awards next year, please nominate people. It's nice just to recognise what folks do. And for me, it really inspires me, and I hope it's inspired you as well to keep driving forward to make the change that we need to in Scotland. And we never have winners in the Newton Award. Everybody's recognised. But every year, Gregor and Judy will look through the nominations and pick one that deserves special recognition. And so, the one that they have chosen this year is the University of Edinburgh Saving Lives student group. So I'd like to invite you to come up to stage. Is anybody who's been involved, please come up. Can we take the microphone a second as well? So you can't get away with just picking up a nice bit of crystal and not saying anything, sadly. I suppose just to ask you guys, where did this idea come from, and where do you see it going next? You can take the mic.
Yeah, I feel like being put on the spot.
Absolutely.
Look, firstly, just want to say thank you so much for whoever nominated us. That was a massive shock. We're incredibly proud of what the group's been able to achieve. It's kind of a bit of a convoluted story to how it came together. Basically, there was a sort of nursing school-led project that was doing community CPR outreach. I got into it through the sort of medical side. When we were looking at trying to combine forces and make sure that we were getting the outreach we needed to, we kind of joined together, and that's how we both came involved in it. And hopefully, we know that near-peer learning, so using students to go out into the community and teach members of the community, is a really effective method of teaching. So hoping that in the future we'll be able to sort of set the standard for how students get into this and how we use this massive pool of willing people to go out and deliver what is a really important cause and close to our hearts.
Yeah, so I think we're still a bit, we didn't even realise we'd have been nominated, so I think we're still in a wee bit of shock. But I also want to say thank you to all our volunteers, and we've got quite a big pool of nursing and medical students who come along and volunteer at our sessions. As was said in the nomination, we've been to lots of different places. We were just at a sailing club on Sunday. We've been into primary schools, high schools. The kids at the schools are always really, really into it and have some of the most amazing questions that you never even would have thought of. But we've had such an amazing time. Myself and the other student on the committee who's not here today, unfortunately, are both graduating this year, but we're very excited to see where the project goes, and we've got very, very big plans. We've been in touch with other universities across Scotland, nursing, paramedic and medicine courses, so we're really quite keen to see where it goes, and I'm sure we'll be part of it for years to come.
And because they cannot get away because they refuse to come up on stage, we couldn't do what we do without the support of the amazing sort of clinical skills team who make sure we're up to date, make sure we're doing the correct training, give us all the kit and come and help support us at the organisation. So the three at the back, we've got Kate, Emma and Lorraine, if they could get a massive round of applause.
Yeah, let's give them...
Not getting away that easy.
Well done. Well, that brings us to the end of the Newton Awards this year. And you're running away from me already. I just want to say thank you so much for always doing this. And thank you for being here. Please do grab them at lunchtime and have a chat with them if you've never met them before. But thank you, Gregor and Judy. So just before lunch, there's no better person to introduce to the stage than a great friend, colleague, and just generally brilliant guy who's come all the way from Canada to spend some time with you today. His name is Steve Brooks, and I'm going to read your bio because it's actually really well written. Dr. Steve Brooks is an emergency physician and resuscitation scientist at Queen's University in Ontario, working to reimagine how communities respond to sudden cardiac arrest. His research focuses on bringing CPR, defibrillation, and trained responders closer to patients, especially in the homes and neighbourhoods where cardiac arrest most occurs. So I'd like you to give a good old Scottish welcome to Steve.
Thank you. Thank you, Lisa, and thank you, Gareth, and the committee for the invitation here today. I actually can't believe I'm standing here. I made it through a very serious man flu that was on the tail end on the flight 2 nights ago, and I almost didn't make it through yesterday. So I'm very happy to be alive and standing here today with a bit of a gravelly voice. This is a profound moment. I was here 10 years ago speaking at SCAS 2016, and to see it still going strong like this is just incredible. So I'm just grateful to be here and share with you some of the things that we've been working on. And, you know, I'm talking about innovation, but if I'm being honest, many of these ideas are stolen from Scotland and taken away to Canada to try there. So I came in 2018 and brought my family. We lived in Edinburgh for a year as a sabbatical. And that's when I was introduced to the Wildcat program and community first responders being such an integral part of the response here. And that is not the case in North America. So I'm just grateful for that experience and being able to learn from Scotland. You're punching well above your weight, and I have a lot of what I'm working on. You know, I have you to thank for that. So carry on. Today, I want to explore one of the frontiers I think we have to address together that we need to work on some more, and that's the cardiac arrest that happens at home. So I'm going to talk to you about some ideas that we're working on in my team, but also some other ideas that are being worked on by other teams. And hopefully we can get at this problem better than we have in the past. So we've made incredible advances in addressing each of these links in the chain of survival over the last few decades. We've made more of the public aware about what cardiac arrest is. We've taught millions of people CPR around the world. We've developed public access programs and increased the number of defibrillators out in the community. And we've saved countless lives. And that is no small thing to look over, but here is the uncomfortable truth, is that where cardiac arrest occurs most often, the things that we need the most to happen in those first few moments of cardiac arrest are least accessible. Early recognition, early bystander CPR, and early AED use. Those are the hardest to access when the cardiac arrest happens in the home. And as we've heard already today, 70 to 80% of cardiac arrests that occur outside of a hospital happen in this setting, where these things are most difficult to achieve. And why is that home situation so difficult? We've imagined, I think we think about the public setting of cardiac arrest when we imagine, the best situation for bystander CPR and AED access, because in public, many of the arrests are witnessed. Many of them have multiple potential bystanders in the immediate vicinity, so more probability that one will step forward and act. And sometimes we're even near a public access defibrillator. But in the home, there's often no bystanders or one bystander. That bystander is often elderly, often untrained, frightened, upset, and they have no access in most residential settings to an AED or defibrillator. So everything's working against us, and as a result, we know that people who have their cardiac arrest at home survive less often because they get less of those important links in the chain happening. So I think what I'd like to do with you today is go over some innovation targets, specifically having to do with the home cardiac arrest, talking about, can we detect cardiac arrest earlier in the home? Can we get more bystanders who are willing and trained into the home? And can we get earlier rhythm analysis and defibrillation in the home? I'm going to start with the problem of unwitnessed cardiac arrest. So in our Canadian data, up to 75% of people who arrest in the home are unwitnessed. And in our system right now, those people are lost. They're lost, they have no hope, because all of the things that we want to do for them depend on the system being activated, on the situation being recognized and triggering everything else that follows through 999. So we know that people who are unwitnessed have miserable outcomes. Less than 1.5% in our data survive if they've had an unwitnessed cardiac arrest. There's a group in Canada that in British Columbia that I work with who have taken this problem on. And they've started experimenting with something called photoplethysmography. And that is essentially the use of light to detect pulsatile blood flow in the finger or the hand or another piece of skin. And the idea is that they might be able to develop a device that uses this technology to detect pulselessness. But I'm not sure whether any of you are going to be willing to wear this thing around 24/7, sleep with it, work with it. And that's one of the challenges that they're facing. And before I go to the next issue, I wanted to talk about this rather creepy idea. Who has a smart speaker at home where you can ask them what the weather is or the news? Right. So there's a group of engineers who are actually working on using smart speakers and something called active sonar, where the device can send out sound waves that are outside of our range of hearing, but they can use the reflections from the room back to the device and actually detect respiratory and cardiac motion. And they can detect when there's a body in the room that has no movement as far as respirations and cardiac activity. So yes, a bit creepy, maybe. I'm not sure if you want that kind of surveillance happening in your bedroom, but just for you to know that there are people thinking about contactless sensors in the home that may be able to detect an arrest and activate things. How many people are wearing a smartwatch today? How many people are wearing a Google Pixel 3 or 4? No one yet. Uh-oh, Google. Not doing well in Scotland. I was going to say, and I'm not sure if many of you are aware, but Google, building on the same technology that I mentioned for my colleagues in British Columbia, have developed a pulseless detection algorithm, and it has been fully implemented in the Google Pixel 3 and Pixel 4 watches. And even more has been activated such that if it detects pulselessness in you, it will automatically dial 999 and relay your location to the ambulance service. This technology has been developed. A man named Jacob Sunshine is an anesthetist in Seattle, and he worked with Google to develop an algorithm using occlusion of the arm and sort of simulation of a pulselessness situation with cardiac arrest, They inflate the blood pressure cuff, remove the pulse, and trained an algorithm to be able to detect that loss of pulse. And they've developed an algorithm where the watch is continuously monitoring with the photoplethysmography, the blue and the green light. If it detects no pulsatile flow in your wrist, then it escalates to alarm the user that it's checking the pulse with a vibration. If there's another 15 or so seconds without pulse detection and no accelerometer movement, there's further alarm, audio alarm, a request for the user to cancel. And if that doesn't happen, an automatic call is made through your device, and 999 receives your GPS coordinates with a possible cardiac arrest call. I spoke with Shorty earlier, and he wasn't aware that any calls have actually gone through Scottish Ambulance Service, but these watches are out there. It's active in the United Kingdom and Canada, and I think we have lots to learn about whether there are too many false positives or whether this is actually has a potential to save lives. Just thinking about detection again, there's lots of work being done at the time of the 999 call. And unfortunately, there are a proportion of calls, 25% in one of our studies, identifying that cardiac arrest ultimately diagnosed when the paramedics arrive was not recognized during the 999 call. So the caller and the call taker didn't pick up that there was agonal breathing and pulselessness, and therefore didn't triage appropriately and didn't offer CPR instructions. There's groups working using AI agents, listening into the call alongside the call taker and flagging or alerting when the situation sounds like it might be cardiac arrest, so that we can decrease that delay to telephone CPR instruction. Really interesting study done with a group of Seattle and Scandinavian authors where they actually deployed this in a Scandinavian call center, had the AI listening to the calls alongside the human call taker, and what they found was fascinating. The AI agent was actually more sensitive at detecting cardiac arrest than the human, but this system was used as a flag, so it sort of held its hand up and said to the human call taker, hey, I think there's a cardiac arrest happening here. They found that the human ignored the AI. And so even though the AI did pick up more cardiac arrest, the human disagreed with it, chose to ignore it, and so it didn't actually change things on the ground. A lesson to us that technology is wonderful, but the computer-human interaction piece is essential. Let's talk briefly about getting bystanders into the home when cardiac arrest happens there. Out on the street, it's easy, lots of people, lots of potential, but in the home, we need to call them in. We did a study looking at the literature, and we found that apps supporting community volunteer dispatch to the scene, they have proliferated around the world. We found 25 different apps in 23 different countries, and what we learned was the heterogeneity, the differences in how the systems work, how volunteers are credentialed, whether they need to be trained before they join or whether they're trained as part of the program, whether they're asked to get a public access defibrillator or whether they're given their own. All of the details of the programs were wildly different. And we learned that if you've seen one community volunteer responder program, you've seen one community volunteer responder program. And I think that the devil is in the details as far as whether these things are effective. So we need to think about that as we go and look at all these different models, trying to figure out which is the most effective way to get people on scene. PulsePoint is the American-Canadian Good Sam equivalent, and we're running a randomized controlled trial, randomizing at the moment of the 999 call to whether the system sends an activation or not. And I know that sounds crazy because we all assume that these things work, but that's not the case. The randomized trial just finished recruiting, and we hope to publish our results in the fall. With respect to the Wildcat program and Good Sam here, this was the most incredible gift that I got from working here. I took this idea back to Canada, the cardiac arrest community volunteer responder. I was embedded here. I got to spend time with the community volunteers. I saw the passion, the level of engagement, and the opportunity. In North America, community volunteer responders are not a thing. They are not routine. In fact, we think we're the first program in all of Canada to attempt this kind of thing. So we stole the idea from Scotland. We rebranded it Neighbours Saving Neighbours. We developed it with some changes that were important for our local setting, and we deployed it after. So I returned home from here, worked on that, got buy-in, and then implemented it. And similar to the Wildcat program, we had volunteers come in and get trained in safe response and CPR and use of an AED. We gave each of our volunteers an AED to carry with them in their vehicle or at home. And we gave them the Good Sam app, and we deployed them just like the Wildcat responders. But we learned some very important failures. And I think failures are the most important thing you get out of a project to help you move forward. We were very successful at rolling the program out. We only had funding for 100 volunteers, and we got those 100 volunteers without any issue, without any expense. We just put social media and mass media out, and they came out of the woodwork. But what we did see was the Good Sam app was working beautifully. So most people we sent alerts to got them and were available. But when we look at the nature of the response and whether people actually got on scene before paramedics or volunteer fire in our community, we didn't see very many people arriving and actually able to start CPR and get an AED on the chest. So we had a lot of people available, but very few actually were able to act. And most of the time, it was because the volunteers didn't get there quick enough. We realized that when we put an open call out for volunteers, the volunteers came from the most populous areas in the region we were trying to implement in. And the most populous areas had the shortest and best professional response times. So we implemented the program in exactly the place where it was least needed. We also recognized that there were some volunteers from isolated country homes separated by many miles in between one home and another, and we recognize this model probably won't work in that setting either, where there's just simply not enough density of volunteers to make a travel time to the next person reasonable. So I think we realized that we need to target community first responders to the areas where there's kind of like a Goldilocks situation. It's the response times are probably not optimal from the professionals, but it's not so rural or so remote that we don't have enough volunteer density to make a reasonable response. We did have successes, and I can say with certainty, you, the Scottish community, Wildcat, transferred over to Canada and saved a life in Canada. That's the truth of it, is that this is our volunteer getting a commendation from the chief. He happened to be driving by a very rural and remote area, got a call, was there within 5 minutes, and was on scene doing CPR for about 15 to 20 minutes, and the man survived to go home to his family. And I can say with absolute confidence that would not have happened without Wildcat, the Canadian program, and this volunteer. So we're inspired by that. Even though our numbers were small in this pilot, we're inspired the system can work when configured correctly. So what are we doing next? I put a $3 million grant into the Canadian government, and we're asking them to expand the program with us. And this time, we're going to use data from 10 years to see where the community first responder program is most likely to have an effect. And not only that, once we decide on those areas, we're going to ask the optimization modeling with a mathematic technique that can help us decide how many volunteers we need to recruit in that area to get a desired outcome. So we're going to use data and math to help us save lives, and that's what the proposal is. So moving on now, I want to talk about getting defibrillators specifically into homes. This is a problem, right? Because most households don't own an AED, and most PAD programs focus on public settings in city centers and otherwise. I wrote this editorial with a provocative title, and I don't mean at all to take away from the importance of PAD, the way we have it right now. And when I wrote public access defibrillation programs here, I meant static defibrillators being placed on a wall and cross your fingers, hope for the best it's going to be used. I was making the point that, look, in our programs right now, 3% of cardiac arrests have the benefit of a public access defibrillator getting on scene. And the situation is even more dire in the home, where it's less than 1%. So to me, that is a failure of an approach to a problem that we have. So we need to maintain that, but we need to build new models of defibs to get them into the homes. So we've thought about this new approach, which is a combination of aspects, many of which are in place here and some of which are in place in North America, but bringing it all together into an integrated approach to trying to get AEDs into neighborhoods, residential neighborhoods. First, we've established that we want accountability from our towns and our cities. Somebody's got to be accountable for this, like they are with fire hydrants and fire safety. Somebody has to take this on as their job and responsibility, and we're trying to arrange that regionally so that someone has an overview of where the AEDs are and where they need to go. So step 2 here is establishing just knowledge of where your AEDs are and where they aren't, developing registry, and making sure that with that registry, once you know where the AEDs are, then you use evidence and data to show you where the next AEDs should go, so that you provide coverage where cardiac arrest is most likely to happen in neighborhoods. We then want to deploy outdoor 24/7 accessible AEDs in neighborhoods so that they're not behind locked doors and they're visible public safety assets like fire hydrants. And we want them to be placed in a way that they're accessible. This is the one that we've prototyped, this model in my neighborhood, and that's on the outside of my house. So all my neighbors know where it is, and it's connected to our 999 in such a way that when they have an arrest within my neighborhood, that cabinet lights up and alarms, so it's more visible when it's required by one of the neighbors. And importantly, the 999 call taker can instruct anyone on the phone to go to the nearest neighborhood AED. And the key piece here, which I think can really take us forward, is that all of my neighbors have the PulsePoint AED app, and they have subscribed to their local neighborhood AED, and they get alerted when one of our neighbors has a cardiac arrest being managed through 999. The cabinet flashes, the neighbors go to my house, get it off the outside of the house and go in. And that happened several months ago. I was called to one of my neighbor's houses, and I took the AED from the outside of my house after being notified on my app. So I think there's lots of opportunity there to use technology and community partnerships to work on this. The last topic I just wanted to touch on with you is the incredible advances in AED technology that give us an opportunity to think not about public access defibrillation, which is important, but about personal access defibrillation. So instead of thinking about these as organizational assets or public things, the technology advances are giving us an idea to think about personal AEDs, like we buy smoke detectors and fire extinguishers for our homes. Maybe the technology will progress to allow us to buy them for AEDs for our homes as well. This is an American company that's, I think, touched down in the UK now, making the Elliott. This is a very small, lightweight, compact, 150 joule biphasic defibrillator for roughly $400 or $500 US. This is another one, Avive, another US company, much more expensive, but really marketed towards the home rather than public settings. And then this company is a sad story. I used to be the chief medical officer for this company. The company is tanked, but the device has survived, and I hope it carries on with another company. This is called the CellAid. It's a single-use defibrillator. I have one in my bag. It's about the size of a large chocolate bar, and it was selling here for somewhere between 360 pounds, I think. But the concept was what attracted me work with the company. Single-use, lightweight, fits in the inside pocket of your jacket or in your backpack. Again, getting away from the fact that AEDs are sort of professional devices and really they're consumer devices. I'll leave you with one thought about technology. So we've talked about things that might be able to get us bystanders, defibrillation in the homes where most cardiac arrests happen. This is laughable at the moment, but not so laughable. The idea of humanoid robots potentially helping us in the home. I'm not sure that anybody here is ready to purchase a Tesla humanoid robot, but this is the Optimus robot from Tesla. They are right now reconfiguring their Texas factory to make less cars, and they're getting ready to produce 1 million of these next year, and with goals of producing 10 million over the next 3 or 4 years. Now that's a Mr. Musk statement, so we can't hold him to it. Don't know if that'll happen. But it opens up some really, really interesting ideas. And just last week, I contacted my Ingenuity labs at Queen's University, a bunch of engineers and AI specialists in robotics, and I said, let's just dabble with this idea and see if we can work on machine vision to detect a collapsed human. Let's see if we can work on the basic mechanics of a humanoid robot, maybe doing chest compressions. You can imagine a future where maybe our robots might get us a cup of tea, and when they come back and find us on the ground, they can maybe do some chest compressions and defibrillators with their hands while calling for EMS. So lots of opportunity to think about things. I'm not the only one who's thought about this. I got this off the internet. It's an Israeli company that has but one page. There's nothing to click on here, but there's an Israeli company that's actually working on this as their prime topic of concern. I'll leave you with that. And just sort of to summarize, I think this is the new frontier, is getting into the home. And I think if we can crack a few of those really difficult aspects of home cardiac arrest, we can make a humongous impact on the bottom line survival of cardiac arrest in our communities. Thank you so much. And again, thank you for the invitation.
Steve, thank you for an amazing talk with so many ideas. It was brilliant to see all the things that you've taken from Scotland to Canada, but many of these things that we can now take, including the failures, and I think that's something that we don't talk about enough, actually, that taking the failures is as useful as anything else, or even more useful, as you say, and then bringing that back to Scotland. We don't, unfortunately, have any time for questions, although I'll put something out there that maybe robots doing CPR. We've got AI now, involved in everything. Do you think one day we might be having robots up here chairing SCAS and giving the presentations? That's a scary idea, isn't it?
Well, there's the big surprise. I am a robot.
And on that note, thank you very much, Steve. That was a brilliant talk. Thank you. Okay, I'm very aware that I am now standing between you and lunch, okay? But Gareth, as always, has given me a bunch of jobs to do, and I'm going to try and remember them. Okay, so first of all, we do have lunch now. Please, there is a first table as you go out, but there are also tables further through, right through to the back room. So please, do find your way all the way through. In one of the back rooms, obviously, we've got our sponsors, so please do go visit our sponsors during lunch. We've also got some great visitors as well. We've got Sudden Cardiac Arrest UK who are here. We've got Chest, Heart and Stroke Scotland. So please do go through and have a chat with them. They've got loads of bits and pieces and shiny things, and I'm sure the teams would love to talk to you. And the final one is the data walk, that as you come out into the room and turn to your right, along where all the glass windows are, we've got big posters up asking some important questions, and we'd really like to hear your answers. So there's pens out there. You can scribble some answers in the box. And again, the great thing about SCAS and about SOUS is about hearing from the membership, and that helps us kind of plan and decide what to do next. Okay, we will see you all back here in this room at 1:40. Please go and enjoy your lunch.
We on, guys? Welcome back. Not sure I'm on. Oh, I am on now. Thank you. Welcome back, everybody. I hope you had an excellent lunch. Again, thank you to our sponsors, Platinum sponsors all, and then Stryker, Ortis, and Corpulse, the gold sponsors. It's them you need to thank for your free lunch, so please, as you get an opportunity later on in the afternoon, go and say hi to them, have a look at their stall, see what they've got. Now, we have a very interesting afternoon, and I realize as we go into the afternoon, there's always a bit of a tension here because we need to keep you awake, and we need to stop you from rushing off to get an early train home / go to the pub, right? And I'm going to ask you, I'm going to appeal from the heart to you not to do either of those things, because we have an excellent afternoon, and we really need your input into some of it. First thing we're going to do is give you some feedback on what people have written on the Data Walk posters. We're going to leave the posters up to the end of the day, so if you haven't had a chance to go and write something on them, then please do. It's an important way, it's a novel way of us getting some feedback, but also letting you engage with some of the information around cardiac arrest in Scotland. There was a big orange poster that said, "Don't just stand there, say something." And Liam will be gratified to know that the first thing written on that list is, when is SAS implementing video CPR? Not the only, whoever wrote that, you're not the only person asking that question. And how can the med tech industry help with SCAS? I think actually the med tech industry funds SCAS, but I think the implication was there that there might be technological ways that they could help. So that's something to think about. There was then a poster which was some reference to Shorty's talk on decision-making and termination of resuscitation. And there were some interesting comments there. There was quite a lot of stuff fed back, and we'll feed through that. But the themes were really about information and clarity in guidelines, and also in confidence, people feeling confident in the organization to back the decisions that they've made. So there's a bit there for us to work through. We had Restart a Heart Live poster. How can we engage more with this opportunity to get CPR training and AED training in front of kids and communities? And there was a lot of helpful information, essentially, which summarizes into find the networks, parent-teacher networks, school networks, local clubs, and so on, and advertise through those networks. So thank you for that. We had a poster about bystander support after cardiac arrest. And very interestingly, somebody suggested that we put the advice line number on public access defibrillators, which seems like a really great idea. We just put the cards in with the defibs. And then there are more comments about hitting as many touch points as possible and getting the word out that this service exists. Somebody's also put, we should be proactive about this. We should contact people rather than waiting for them to contact us. And we'd really like to have a system like the Norwegians, who send an SMS or a text message to the bystander who's called into ambulance control to proactively offer the opportunity to contact. And that's something we're certainly looking at in the Scottish Ambulance Service, though there are some technical hurdles to overcome in order to do that. Good SAM was the next poster. How do we increase Good SAM signups? And there were some interesting comments here, trying to potentially increase the range for Good SAM responders in rural areas. And that's an interesting conversation which would spill over into a discussion of when is a Good SAM responder then a community cardiac responder. And then somebody's written something that I think a lot of folk would resonate with. Only alert to out-of-hospital cardiac arrest, not dead people. And if only there was a way that we could, in a foolproof manner, make sure that we didn't respond to dead people, that would be great for all of us, I think. So it's an important comment, and it's something that we would like to refine, but it's a difficult challenge. And then finally, public access defibs using PADMAP. How do we encourage the public to use PADMAP as a tool to help them place public access defibs in areas where they're most likely to be used? And there are some comments here about lack of confidence currently in using pads. In fact, that's mainly what has been signposted here. So it's about people getting more confidence in order to be able to use the pads that are there. And also, someone else has commented, it's very difficult to move a pad if you discover it's not in the right place. And we'll be hearing a bit more about that this afternoon. So that's a flavor of what you guys have fed back. Thank you very much for doing that. And we will digest and respond to what you've put. So, we're going to move on now to our next speaker today, who is someone who I've heard so much about. Everybody said to me, you know, you should get Wrong to come and speak at SCAS. He's really good. He speaks really well. And he's amazing. I'll tell you later who these people were who said this wrong, but I'm not making this up. And we've tried. Believe me, we've tried. This is not the first SCAS where we've asked Ron to come and speak, but he's a very busy guy, interventional cardiologist at the Royal, originally trained in Melbourne. And he's come to give us a cardiologist's insight really into further down the pathway of out-of-hospital cardiac arrest. And it's with huge pleasure that I'll welcome Ron Bing.
I think I'm all good, all good. Thanks, Gareth. What a way to set me up for failure, mate. Thanks very much. That's all good. Look, a pleasure to be here, and it's a big room, so it's not a great day to have an arrest on the streets of Edinburgh, is it? So lots of crews here. So yeah, this is just a chat. This is opinion-heavy and data-free, right? Because I guess you guys see a lot of undifferentiated arrests, and you are the front line, and I'm conscious that what I see is like almost like an ivory tower view, right? So they get filtered out. There are many cardiac arrests that I don't have to see. And so it's just to kind of unmask a little bit of what goes on once they come through our doors, once you've got them through the hospital and it's a cardiac problem, okay? So are there any Aussies in the room? There must be. There's got to be, yeah, all right, yeah. So I know I've met Aussie paramedics in it. You seen this? Seen Kenny? No. Yeah, fair enough. About 2000, Kenny, this is Aussie classic, a fantastic film, Shane Jacobson, highly recommended. And I'm showing this because Kenny is a plumber, okay? And it's important that you all understand a little bit about me, right? Because all your speakers have a little bit of bias, okay? So you've got to understand what are my biases, okay? My bias is I'm a plumber, I'm Kenny, okay? So I am an interventional cardiologist. I think everything is about the coronary arteries. I see a stenosis, I've got to fix it, and I'm a simple plumber, okay? So cardiologists are not the brainiacs of cardiology. It's probably the electrophysiologists. So for me, I like to keep things really simple, right? So that's Kenny. And I do think the coronary arteries are amazing. Core principles, and this is not just about today, it's just fundamental things which I tell all the registrars which do apply. So I think the basics are really important. So history for patients that we see with cardiac arrest, absolutely crucial, absolutely crucial. When you can get a history, collateral history, can sometimes make all the difference when it comes to diagnosis and management. And you'll not be surprised to hear that a cardiologist thinks an ECG is really important. Okay, so more ECGs, the better. Be liberal. Use all the paper, run all the rhythm strips. I'll look at them all. Okay, so ECGs are really important. And then you don't need me to tell you this. Okay, so whatever else you do, whatever needs to be done immediately, and then everything else can wait. Okay, so I'm not fussy about a cannula that's in the right radial. Okay, this something, it doesn't matter. So you guys do what you need to do. Get what needs to be done quickly, and then everything else we can deal with afterwards, okay? So, how do we go from here to here, home, okay? So the chain of survival, I guess, talks about a lot of the immediate actions, but really the chain of survival does extend to, ideally, discharge home from hospital. And different patients go through different journeys, right? Some go to resus, some never need to go to resus, some come to the cath lab, some don't come to the cath lab. Some people go to ICU, sometimes some go west, right, to Glasgow if they have shock that's refractory, need a transplant, and some of them go to the ward, and hopefully patients go home. So what happens for us, and what am I thinking about when I see these patients? I will recognise that the most important thing here when it comes to the ward care is that for a lot of these patients, once the immediate stuff is done, the cardiologist is often not very useful, okay? So a lot of the aftercare of these patients is based around nursing care, allied health care, rehab, and I'm not doing very much, okay? So that's really important. It's a real team effort to get these people home. So the emergencies. So initially, the emergency is what you've dealt with, but when you bring them in, say, to resus, and say, Gareth calls me to come down and see the patient, what am I thinking? Okay, is there something that's meaningful that needs to be delivered emergently that is going to change the management of the patient and change their outcome? And do I need to do something now? Okay, so that's the first thing that's in my mind. And what are these things that cardiologists can help with? Because, you know, if this is a non-cardiac cause, there's not much necessarily that I can do. Okay, so this is for cardiac problems. I like to keep things simple. Number one, ischemia, obviously. Are they having a big MI? Okay. Number two, is this a refractory arrhythmic problem? Okay. So some of these patients have a primary arrhythmia. Are they in some sort of refractory arrhythmia? And then for me, number three is, are they in terrible shock? Okay. Are they in pump failure, usually, or obstructive failure, but mostly pump failure? Cardiogenic shock for some reason, and they're dying from that when they come through the front door. Okay. Simple buckets for me, and therefore, the answers can be, broadly speaking, relatively simple. So what's the answer for someone having an infarct? Open the artery, okay? Easy. Everyone knows what this looks like. Everyone looks at this and probably thinks that's not very nice. So right bundle, anterior STEMI. That needs the LED opened, okay? How do we assess these patients? ECG, 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 okay? History. Echo, useful, okay? We'll come in, stick a probe on. If there's any ED physicians here, POCUS, okay? And then blood gas will be very useful for prognostication often. Ugly, everyone will agree? Don't like saying this, okay? Yeah, it gives you heebie-jeebies. This is someone who's obviously having paroxysms of VT, and this is an arrhythmic problem, okay? So, ischemia, open the artery. So bearing in mind that ischemia doesn't necessarily mean it's an infarct, but if someone's HB is 40, they're probably ischemic. But I'm really referring to an acute arterial occlusion, okay? So occlusive MI, open the artery. What do we do if there's an arrhythmic problem? Okay? It sounds a bit silly, understand the problem, treat it. And it's a bit silly because it's obvious. But the point of this is there can be different substrates, right? So some people can actually have bradycardic VT arrests, right? If they're having R on T and their base rate's really slow, and the paradoxical treatment for them, you've got to speed them up. So you give them isoprenaline, pace them. Other people are having refractory VT because they've got tons of scar from an infarct, and treatment for that patient is probably some sort of anti-arrhythmic like amiodarone. Okay, so understand the problem, direct your treatment at that problem, and then if someone's in shock, if someone's in pump failure because they've got terrible cardiomyopathy, we need to either support the heart, support the organs, or do both. Okay, and sometimes supporting the organs is at expense of the heart. We have to remember that. Okay, and the other thing is, although I've divided these into three big buckets, sometimes one big bucket. Okay, so sometimes a patient's got lots of scar, they're ischemic, and they're having lots of VT, and they're in shock all at the same time. Okay, but I like to keep these things simple because it helps direct your treatment. Once we're past that acute stage, now we're getting into the kind of, they're on the ward, or they're in ICU, stewarded somewhere, they're in ICU, they're stable. What are we thinking about the underlying problem? Okay, so now we can get into the kind of cerebral thinking about things. And now I like to divide things into small buckets. What's the underlying pathology driving this if they've become stable? Okay, so first, heart muscle. Is there a muscle problem? Okay, so do these patients have some sort of cardiomyopathy? So hypertrophic cardiomyopathy, dilated cardiomyopathy, arrhythmogenic cardiomyopathy, or have they acquired some bad thing? Right? They have lots of scar from an old infarct, maybe they've got sarcoid and myocarditis. Okay, and this is probably the biggest bucket you'll see of patients of heart having an acute MI. It's very common. Okay. Next, is there something structurally wrong with the heart? Less common, a bit more niche, probably limited to things like severe aortic stenosis and congenital heart disease, which scares me, and I don't want to talk about it. Okay, and the final box, which is less common, but probably some of the worst ones you'll see because these are young patients, are primary electrical problem. Okay, so Brugada, long QT, short QT is very rare. pre-excited AF, right? So AF going down an accessory pathway causing VF. So these are scary. They're not common, but they're scary because this is 20-year-olds, 30-year-olds that you guys will see, okay? So that bucket is less common, but scary. And this is the only data slide you'll see, and it's a bit small up here, but this is from 2022, okay? ESC guidelines on cardiac arrest. It's a very useful thing. And all you need to see, so on the left-hand side, they've listed a few different pathologies here. In the middle, you'll see the big plots here of where the peak incidence of these conditions are when they arrest, and the age at the top. And for those at the back, I'll talk these through. So those two there, that's acute coronary syndrome and chronic coronary artery disease. You can see that by far, this is the biggest volume, looking at those plots, okay? And the peak incidence is around the 60s, mid-60s, okay? A big wave like that. In the middle, these three, those boxes there, that's the cardiomyopathy I was talking about, okay? So you can see smaller boxes, slightly younger, and then electrical problems at the top, the ones I was referring to before, okay? Things like Brugada, non-QT syndrome. You can see this is a preponderance of incidence in young people, young cardiac arrests, all right? But the absolute rate, small. So that's really all I want to say. I mean, that's how I kind of think about these patients, and I'm going to compare and contrast two tales, okay? And then we'll finish up. So this is two blokes that have come in, and maybe some of you resuscitate these two fellas. So in the last 2 years, okay, they've come in, and I'll tell you, this is an accurate pictorial representation of what was happening when these two fellas arrested, okay? So that guy, when he arrested, 90, okay? He was walking with his wife. You'll see that at here, A&E, okay? There's a hospital in the background. He was walking with his wife to his wife's dermatology appointment in the Lauriston buildings, okay? And they got there, got into the building, and he had his arrest, okay? The other fella is 22, okay? And he was running, he was out running, he was at the gym, he was running, and he had a cardiac arrest, okay? So there's two different people, one at the start of a young, fruitful life, and the other fella towards the end, okay? They both had a cardiac arrest. So what's the difference here? So what was the clinical history, because I've said the history is important, in the 90-year-old? So this guy had no antecedent symptoms, although he's 90, fit and well, right? Walking up hills, enjoying life, and he got resuscitated immediately by a dermatologist, okay? So got defibrillated for a VF arrest. Now what's his past history? Really important. Well, 2 years before this, he'd had an anterior MI, okay? But because 2 years before this he was 88, we managed him medically, he's been fine. So after an MI in 2 years before this, he was totally fine, no angina, no heart failure, no symptoms, and on good treatment and good medical therapy. That's his only past history. And mild to moderately impaired ejection fraction. It's a pretty good shape, okay? And then what's he like when he comes into resus, okay? You would not believe it. He was absolutely fine. Sitting up, chatting, wife was there, quite relaxed, nothing, it was like nothing happened to him. Honestly, he was unbelievable, all right? So this guy, that's his ECG. So you probably all agree that is not an acute myocardial infarction with a blocked artery, okay? So is there something acute that needs to be done urgently for this man? Don't think so. ECG doesn't show an acute infarct. He's not having refractory arrhythmia, and he's not in shock. So we've got time to think about things. Punt him up to the ward, have a look at him, have a think about what the problem is. It's very obvious, right? This guy's got scar from an old infarct, and he's had scar as the substrate for his cardiac arrest. So this is an ischemic cardiomyopathy. So I remember I got the ED consultant on that day, he said to me, "You're not going to take him to the cath lab?" I said, "No. Why not?" Well, what are we going to do? So the idea here is that taking this guy to the cath lab is not the answer, right? Because he hasn't got an acute coronary occlusion, right? The problem is scar, okay? And what did I do for this man? Gave him amiodarone, sent him home. 3 days later, it was 2 years ago now, he's fine, okay? So this is medical therapy in an older patient with no symptoms preceding and ischemic cardiomyopathy. He's done very well. And just to show, so this is the same box, right? So he belongs in this bottom box, chronic coronary artery disease. And for those at the back, I'll tell you that the scale of the age goes up to 80. So he's off the chart. He's too old to be on the chart for the European Society of Cardiology, okay? So the next young fella, super active, right? Again, he's got no past history, doesn't take drugs, there's no family history, cardiomyopathy, nothing, right? Except ever since he was a kid, every so often we'd be running, and this guy's a fitness freak, right? Runs all the time. He'd occasionally get sense of palpitations, rapid, but never passed out, never had pre-syncope, totally fine, and he just always ignored it, okay? So it didn't really trouble him until this day, cardiac arrest, okay, at the gym. On arrival at ED, this man is not fine. He's stable hemodynamically, low GCS, intubated, off to ICU goes. So what's this guy's clinical course, all right? Very different from the 90-year-old. ECG, I'll tell you, this is a normal ECG. There's no hint of any channelopathy, accessory pathway, ischemia, cardiomyopathy. It's normal. Bedside echo, normal, okay? Bloods, normal. Again, obviously there's no acute problem that needs emergency management when he comes in because his arrest has happened and he's stabilized. And so what's his problem? The truth is, I don't know. At this stage, very hard to know. Could be several different early cardiomyopathies. Could be some sort of channelopathy. Don't know. So we do get these patients in, and these are the ones you'll drop off to us, and you might not know what happens to them, okay? So what happens to a guy like this in hospital? So 2 weeks in ICU, pneumonia, line-related DVT, quite delirious, okay, quite delirious, and eventually comes good, okay? And I'll tell you that we did every test we could think of, and they're all normal, okay? MRI, looking for scar, no scar. Various kind of tests, treadmill tests, Ajmaline tests, looking for nothing, okay? And this happens as well sometimes. So at the end of the day, after all these normal tests, I had to say that this was probably just maybe some sort of early cardiomyopathy we just hadn't found, but it's basically unexplained. Unexplained. So we don't know what the problem was yet, so we haven't given him a directed treatment for the cause, but we want to protect him from dying again, obviously. So defibrillator, beta blocker, home, okay? You've all been called out to see patients with defibs who have gone off, I presume. So this young man immediately started running again. Taking his beta blocker, he started getting these palpitations again, and then gets some shocks, okay? Boom, okay? That's what it looks like. So if you get a readout from your ICD, you get this trace, okay? So you can see he's in sinus rhythm, he's tachycardic because he's been running. Then out of nowhere, monomorphic kind of broad complex tachycardia. And then you get a little zap symbol here because that's the zap, that's his defibrillation. He gets a shock. And I'll tell you, he was depleting his battery on his ICD because he said he wasn't taking his bisoprolol, but he kept getting these shocks. And it's obviously unsatisfactory. So the one test that we had not done was an electrophysiology study, which the EP guys, remember I said they're the brainiacs, they initially thought probably wasn't going to be very helpful in this case. But at the end of the day, it's a young fella, unexplained. It's the one test we haven't done. Why don't we just do it? So I talked him around to it, and this is a picture. If you ever come to the cath lab, you've seen the coronaries. This is the kind of stuff that the EP guys stick in. So there's 2 or 3 catheters within the heart in different parts of the heart, and they map out different signals and see where everything's coming from. And lucky enough, they did find a cause. Extremely rare, and we're going to put in as a case report. Basically, he had Wolff-Parkinson-White. And he had AVRT, so a tachycardia through the accessory pathway, which was probably what he got shocked for, but he never had AF, okay? So it's very rare to arrest from Wolff-Parkinson-White if you don't have concomitant AF. So this is an extremely rare case, but they ablated it. And lo and behold, immediately afterwards, he's been fine. No symptoms, no palpitations. He's running better than ever. Actually, he's really happy. Okay, so this is what happens. We often kind of go through a kind of barrage of tests to find out what's happening in young people. Okay, and this guy is nowhere on this chart. He's nowhere on this chart. All right. So that's it. That's all I really want to say. So my final thoughts, I suppose, are from the start. So basics, really important. So the examination, the history, ECG, I love an ECG, okay? Deliver your meaningful interventions as quickly as you need to, okay? Do what you need to do, don't worry about anything else. Everything else can come later. And then, obviously, the final thing is that there's no survival to hospital discharge without you guys bringing them to hospital live first. Right? So thanks very much for all the good work, and I'll see you around. Okay.
Thank you very much, Ron. We've got time for one or two questions, if that's okay. Is there anything anyone would like to ask Ron while we have not just one, but two cardiologists at SCAS today? You might need to wave your hand if you've got it up, because it's quite bright here at the front.
It's Steve Brooks in the back of the room.
All right, mate.
Thank you for that. I just wanted to ask you, I know you're not an electrophysiologist, but we spend a lot of time trying to think about ways to get the AED event data to the hospital more consistently. But I'm always wondering why we think about that so much and how often it actually is useful or changes the course of investigation or outcome for patients who have been resuscitated in the pre-hospital setting. Yep. So can you just tell us like how useful it is to have the AED event data, including the CPR profile and the cardiac tracing?
Yeah, thanks. It's a great question, and we chase it as well sometimes, because for obvious problems, it's not necessary. In most cases, it's probably not necessary, but occasionally you're left wondering, what was the rhythm? What did they really get shocked for? Was it artifact? Was it polymorphic? Was it monomorphic? Because in a small subgroup of patients, the type of dysrhythmia, when you have no other clues, can be a hint as to which path to go down. And so if there's polymorphic VT, if there's R-on-T that's captured halfway through, if it's monomorphic VT, it can be really useful. And it can be useful to see the QRS complex after they've been resuscitated, if you get ROSC back as well. So it is probably something that is, it'll be great to have. It's maybe lower down the list of priorities when it comes to things that we would like to have, but yeah, it's good.
Great, thank you. Any other questions? Got a quick question for you, Ron. And if there was one thing that makes you roll your eyes or kind of grit your teeth when out-of-hospital cardiac arrest come in, and you think, you may have already mentioned it, but you think if only this had happened pre-hospital, or they've done that thing again, I wish they wouldn't do. Is there anything you'd like to say to a keen, enthusiastic group of frontline ambulance service clinicians about out-of-hospital cardiac arrest from a cardiologist point of view?
Thanks, yeah. So there's like a want column, right? And then there's your dreaming column, okay? So the want column is just ECGs, right? If there's a wherewithal to have an ECG, bring them all along. That can be diagnostic, it's really useful. But the truth of the matter is, and actually, to be perfectly honest, it really bugs me when people, you guys bring patients into the lab, and there's a bit critical about this or that, because frankly, I'm in no position to say to you how to do your job, right? It doesn't matter. For me, the patient comes to me in whatever state you can get them here in a safe manner that you deem fit. So you are the caregivers, and then I work with what comes, okay? So as far as I'm concerned, it's not for me to say what you should do. You guys, you carry on, and then I don't care where the cannula is, I don't care this, you just bring them, we'll deal with the rest, okay? So an ECG is great, but otherwise, I'm not here to say how you should do your job, yeah.
Ron, thank you so much. And if the cardiology doesn't work out, there's a career in international diplomacy. Thank you so much. Thank you. Now we're going to try something a bit different. And over the next 45 minutes or so, I want to give you a flavor for what's coming next. What I think is one of the next big things around out-of-hospital cardiac arrest in Scotland, and that is care zones. And I've called this few minutes of introduction that I'm about to give What are cardiac arrest rescue zones? That's what care zone stands for, just in case you were struggling to make the connection after all those sausage rolls. So what are care zones? But I actually want to start the conversation a little bit further back than that and say why care zones? And then we'll talk about what they are. And then we've got some friends from Dumfries and Galloway and Scottish Ambulance Service and other places who've been putting this into practice, who are going to tell us about that. And then we're going to explain how we need your help. All right, so that's where we're headed over the next 45 minutes. So firstly, why care zones? And in order to get into this, I want to introduce you to two models, which you may have seen before, but two mental models that I think are really, really helpful. And this first one is adapted from a chap called Charles Handy. You may be familiar with Charles Handy. He writes books. He's a philosopher. He's really into organizational behavior, business behavior. And he's got this thing called the S-shaped curve. And he, first of all, described this in a book called The Age of Paradox as a way of talking about how businesses perform. And then he liked, like this happens quite often, he liked the idea. And so he brought out a bunch of other books about how this curve is actually the answer to everything. It describes everything from how businesses perform to human life to the lifespan of an idea, everything. And it's quite a fun idea, so let me talk you through it and then explain how it relates to care zones. This curve actually describes performance or impact, or it could be growth over time. And if you look at the curve, you see that when an idea is new and everybody's dead excited about it, it starts off here. And then it maybe has a dip after the honeymoon period as you begin to find your feet. But then it picks up and you get some growth. And if it's a good idea, if it works, then you get a period where things go really well. And over time, performance or impact increase. But then inevitably, as surely as night follows day, with every idea, with every innovation, no matter how good it is, no matter how special it is, that begins to trail off as you reach maturity. And what Charles Handy says is, listen, the best time to think about the next thing, to begin to do something new, is not after you've got to the point where you've passed maturity and you're into drift and despair and death of the idea. It's before you get to that point, while you're still at the top of the crest. And that's when you should think about the next idea, the new start, before the first curve runs out of momentum. Because once the first curve runs out of momentum, nobody wants to know anymore. You've got no money left, you've got no enthusiasm left, you've got no credibility left. But the problem with starting the second curve before you get to the decline is everybody says, well, why are we doing something new? What we're doing now works perfectly well, or it seems to be. We've had all this growth over this last period of time. Why on earth would we start something different when what we've got is working? And my suggestion is that the parallel here is with the existing cardiac arrest strategy, which comes to an end this year. This is the end of the 2021-26 strategy, and care zones. What we've done since 2015 and the first strategy has changed the face of cardiac arrest in Scotland. You guys have changed the face of cardiac arrest in Scotland. Bystander CPR is up from 40% to over 60%. Survival has doubled from 180 odd survivors a year when we started to over 360 now. And that's because you've got 3 times the likelihood of having a public access defib used. We've got all sorts of different kinds of secondary response to cardiac arrest with the Scottish Ambulance Service. Things have changed significantly. But I would suggest that we're just heading to the top of the curve. Andy Lockie showed data earlier on today that showed our survival figures going up and just beginning to flatten out after the rebound from COVID. And now is the time to do something different, and care zones are that different thing. So mental model number 1, the second curve. It's time to jump into the next curve. Mental model number 2, the Utstein formula for survival. This is a very interesting, totally made up, but interesting mental model. And what it says is this: for survival, you need 3 things. You need medical science, and that's essentially what's in the guidelines. So we need to know what do the clever people like Wrong and like Andy think we should be doing to get people's hearts restarted. But then you need educational efficiency. You need to get that guidance and communicate it to people like us who are involved in the front line, involved in the community, involved in the emergency departments, implementing those guidelines. But then you need local implementation. So it's okay having the thing to do and knowing what to do, but you've actually got to have a system that allows you to do it effectively, the right time for the right patients in the right place. And these things multiply. So let's say the medical science is really good. Maybe not 100%, but maybe it's 80%. And maybe the educational efficiency is pretty good. Maybe it's 60%. But then you've still got 60% of 80% by the time you get here. And then maybe local implementation is a bit patchy, and maybe you've only got 20%. So now you've got an even smaller fraction of your guidelines getting through to the end of the process. So we need something new, we need a second curve, and we need to fix the problem of local implementation. We know what to do, it's been established, we all understand what that needs to be, we've been educated, but how do we locally implement what needs to be done for cardiac arrest? And that's the care zone approach. So care zones look more complicated from this diagram than they really are, but really it's about taking an area of Scotland, let's say a council area. We understand what improves survival after cardiac arrest, but how does that work in any given area? So we select a council area, and in the example we're going to talk about this afternoon, it's Dumfries and Galloway. And we went and we had a chat with folk from the council, and it took us a couple of goes. We had a couple of false starts. We weren't very good at explaining the problem initially, but eventually we helped them understand what was required to improve survival after cardiac arrest. You need to identify the arrest. You need to do bystander CPR. You need to have defibrillation. And in order to get that, you need to teach CPR in schools. You need to do it in the community. You need public access defibrillators. You need community responders. You need good SEN. And once we'd articulated that, we then found out what was already going on in the area in Dumfries and Galloway. There were already organizations that were doing some great work, so let's help them. Let's find out what the people living there really want to do. How's it going to work in your environment? What this looks like in Dumfries and Galloway is going to be very different to what it looks like in Greater Glasgow, for example. And then we build a plan. Get the Coalition of the Willing, Assembly Avengers, Fellowship of the Ring, whatever your favorite metaphor is, and we make a plan. And we use the data that we collect as a service and as a research group to implement and evaluate how that plan is working. And the data looks like this. We've got information about cardiac arrest risk. We know where the cardiac arrests are happening. We know how long it takes to get an ambulance to a cardiac arrest, virtually anywhere in Scotland. We know about CPR rates and where pads are being used and where they're not being used, where there are good SAM volunteers, where familiarization is happening in schools, and where there are community responder schemes around Scotland. And so we put all that data together and use that to inform the plan. And clever people within the ambulance service, like young Donald McPhail, will be able to construct these kind of maps. And this is done for those of you unfamiliar with the shape of Dumfries and Galloway, that's what it looks like on a map. And there are two examples of the data that we've been discussing. One is response times. And then you can see the shortest and longest response times to different areas. And this is pad use, public access defib use. Where are the areas where we need more defibs? But it's not just maps and small numbers, because that's great if you're really immersed in this, but what if you're not immersed in out-of-hospital cardiac arrest? What if you're not used to looking at maps and response times? How do we make some of this information more accessible? And actually, how do we make it accessible to everybody? Our aspiration is that councils and people interested in cardiac arrest provision in their area wouldn't have to come to the ambulance service and ask. We wouldn't have to read a special report or have special permissions, but the information will be available freely to everyone who's interested to start conversations and help people build better systems. So what I'm going to show you next are just two more slides that are not a finished product, they're not prime time, but they're a glimpse of what might be possible in the future. This is what happens if you try and stack up cardiac arrest risk, so number of cardiac arrests per 100,000 of the population on this axis, along with deprivation along the x-axis. So percentage of the population in SIMD1, poorest 20% of the population. Each one of these circles is a council area. Size of the circle is the population. You can see some are little tiny island ones, some are much bigger. Glasgow City, so not GG&C, but Glasgow City, Edinburgh City. But it's interesting when you do that because you see little outliers appear. Poor old Inverclyde. Inverclyde that has almost 40% of its population in SIMD1, one of the most deprived parts of Scotland, and has the highest rate of out-of-hospital cardiac arrest anywhere in the country. And this kind of data really could be used to inform planning. Where do we start with care zones? What do we say when we go to Inverclyde Council and say, we need to help you make a plan to improve survival after out-of-hospital cardiac arrest in your area? Here's one more map. This is a slightly busy one. I put this in here partly to respond to a comment that Steve Brooks and I had in discussion yesterday. When you get to a council area and try to explain what do you need, you've said 5 things here. You've said school training and community training and PADS and Good Sam and responder groups, but what do we need and where do we need it? Well, the data can sometimes help us there as well. So this is Dumfries and Galloway. These are the wards, so the sub-council areas, if you like, and they're all very different. Some are very remote and rural, some have larger populations. And if you take all the data around cardiac arrest rates, response times, where the pads are, all that kind of stuff, and you put it through the mathematical sausage maker, you can generate this kind of dashboard. So here, what we've done for each of the wards is we said, well, look, let's add up how likely it is that the population are living close enough together that pads on the wall will be a good idea, and we'll make a pad score. And then let's factor in how long it takes an ambulance to arrive on average, and how far apart the population is in other parts of the council, and let's make a responder score. And then we can have a recommendation, mathematically, which you can use to help inform the planning. So for each of the wards in Dumfries and Galloway, here's a recommendation. In Abbey, we should have responders, whereas in Lochar, we should have pads on the wall. And there are other places where we should probably have both. And this is response time in minutes, the median, and that's the can't remember what that is. But you see, providing this data is not telling people what to do. It's not prescriptive. It's not computer says this, therefore you should do it. But it's giving people the tools, giving council members the tools, giving schools the tools, giving people who live locally in communities the tools to understand the shape and size and scale of the problem in their area, and to work out which of the many things they could do will be the most appropriate implementation for their context. There are many things you could do. Not all of them will work equally well in all geographies. So finding which is the one we should reach out for is part of the Care Zone project, making implementation work locally for the people of a given area. So what I'd like to do then is invite some guests from Dumfries and Galloway, some of the team involved in Care Zones, to come and join me on the stage. When each one comes up, I'm going to let them introduce themselves, just to say who they are, because then I don't have to remember everybody's Sunday titles. And I'm going to ask them one question about what they've done. After we've gone through that, we'll then have a little bit of Q&A at the end. So as you're listening to what people say, if questions are bubbling up in your mind, hold on to them, and then get ready to ask them at the end. Does that all make sense? Seeing a few nods. I don't know if that's just people falling asleep or whether it's... Excellent, great. So, Gillian and Barry, would you mind joining me up on the stage? Let's have a big hand for Gillian and Barry. It's one mic, so you'll have to share. Thank you both for joining us. Barry, do you want to tell us who you are?
Hi, everybody. I'm Barry Watson. I am the transformation lead working out of clinical services in the ambulance service, and I help to manage the project of implementing the Care Zone pilot in Dumfries and Galloway.
Great to have you with us, Barry. And Gillian, do you want to tell us who you are?
Good afternoon, thank you. I'm Gillian Bryson. I'm Executive Director for Education, Skills and Community Wellbeing for Dumfries and Galloway Council. So I'm responsible for our schools and our community and a wide range of services within our council. So it's a great pleasure to be here.
So Gillian, just hang on to the mic there, and I want to ask you both just one question. We could talk all afternoon because there's lots to cover, but just to give a flavour. Gillian, when we came with this idea and tried to communicate to you, cardiac arrest is a public health problem in Scotland, and we need your help to fix it. What was your understanding initially, and what was the kind of journey you went on in trying to understand what on earth we were trying to say?
Thanks very much. Councils, as you might know, are quite specific in terms of delegations and committees, and there are very specific rules and regulations. I'm sure they work similarly to your silos within NHS. So when this came to me, Chief Executive's Office gave it to me because it had health in the title, and I thought, why is this my job? Surely our NHS colleagues are going to be frustrated that I'm, as in charge of schools, that I'm getting involved in this. I don't want to step on people's toes. I don't want to interfere. This is not my area of expertise. And the couple of false starts that you referred to, couldn't see what this is. So why am I the person that's best placed to do this? And then the penny dropped, and it was one of our Scottish Ambulance Service colleagues who basically said, it's a public health problem. It's a health problem when they get to the hospital, but we've got to be alive by the time we actually get them in the ambulance. And it just made me realise that I did know a lot about CPR. I know a huge amount of CPR, but my CPR is about community participation and resilience. It's a different kind of CPR to what you're good at. It's all about connections and permissions and reality. So I work in a different world, but joining my CPR with your CPR, I think is where we started to understand. And Gareth told me the story about the double-decker bus, and that was one of those, just make it real for people. There's a double-decker bus of people who have an out-of-hospital cardiac arrest every week, and only 4 out of 10 of them survive. And all of a sudden, it made sense that I can do something, because I understand our communities, I understand our resilience, and I understand how to communicate that message. But you're the experts, but I can help you.
Julie, I love that community partnership and resilience. I'm going to steal that from you, Barry. So it's a brilliant realization. That's what happens when you get medics to try and explain things that aren't medical. You know, it gets misconstrued. But cardiac arrest isn't a hospital problem. It's a community problem. And Barry, we were trying this for the first time. We hadn't done it before. We were making up as we go along. What were the challenges in terms of getting the apparatus, the process together to make care zones work, to get the right people in the room and so on? What were the initial challenges?
Well, I suppose the whole thing, we always say that care zones is like a hyper-local approach. It realizes that every council area, every community has its own distinct characteristics. It's about sort of tailoring a solution designed to complement those unique characteristics. So I suppose when you go into a place like Dumfries and Galloway and you're going in cold, you want to be open to getting help from all sorts of different people. But by the same token, you don't necessarily want to go in and have like a town hall meeting where you're getting everybody to put their hands up, because that'll just be unmanageable. So I suppose it's the challenges was trying to identify sort of a small stakeholder group in the first instance, local leaders and decision makers who had sort of the authority to make decisions, take actions, and the reach to link us in incrementally with other people that can help, rather than getting everybody involved straight away. So we were really, we're really lucky in Dumfries and Galloway to meet up with Gillian and her team. We had great help from DH9, who were mentioned earlier in the event, and we had great buy-in from our Scottish Ambulance Service local subdivision as well, and they all helped us formulate a pretty tight plan, and then expand that plan and get more and more stakeholders involved as we went along.
Brilliant, brilliant. Thanks, Barry. if you two wouldn't mind just grabbing a seat in the front row, I'm going to grab you later for a bit of Q&A, and if Roger and Susie want to come up and join me. Really helpful. So this group of stakeholders was assembled, and Barry boiled down what needed to happen into 5 levers. And those levers, if you like, those things that if you do these things in some degree, in some way in your context will result in greater survival, were training in schools, training in communities, public access defibs, Good SAM, and community cardiac responders. And Roger and Susie, you've both been involved in 2 of those levers in Dumfries and Galloway. Do you want to introduce yourselves first of all?
Hi, I'm Susan Gardner. I work for Save a Life for Scotland, very closely with Gareth and Dominica.
Hi, my name's Roger Hill. I chair the DH9 Foundation, which is a small local charity which has only been in existence for 18 months.
So, Roger, hold on to the mic there. You're involved in lots of things. We've heard a little bit during the Newton Awards, actually, about just how much you guys have achieved in a very short period of time. But focusing in particularly on community training and community familiarization, can you talk about maybe one of the ways in which things that are particular to Dumfries and Galloway, where you were able to work in your favor in terms of reaching large numbers of people in the community?
Yeah, so I used to work in education, in senior position education in different education authorities, and worked in Dumfries and Galloway prior to retiral. So therefore we had a link in there into the schools, and that we've now visited and been part of training in schools, free voluntary training across nearly half of the schools in Dumfries and Galloway in that 18 months. But we've also reached out to, there's a huge youth festival called Youth Beats, which has 20,000 participants each day over 2 days, 40,000. And we were invited to be the health partner of that last year, and we're going to be a health partner of that this year again, marquee, and we'll be doing CPR training all day throughout both days. So there is a link into that. And just to pick up something Andy said earlier this morning about CPR being compulsory in Scottish schools, and it's not. The policy intention is that CPR training is compulsory, but it's not actually, and it takes the goodwill of individuals to actually make that happen within the schools.
Yeah, so top down is there, but bottom up needs a bit of work.
Absolutely, we need to bring everybody on board.
And so that's a great illustration of how implementation in Dumfries and Galloway looks different, because they happen to have a rock festival of 20,000 people a day coming through the doors. So that's a place, an opportunity can be taken. But that's not going to be the same in every council. Susie, do you want to tell us, your work in Save a Life for Scotland has been focused on many things, but one of them is Restart Our Heart Live and what happens in schools. Dumfries and Galloway have done some interesting things, or beginning to do some interesting things around schools engagement. Do you want to outline what's been going on?
Yes, so the council were amazing. I worked with Lindsay Green, who was dealing with the schools and well-being. So Lindsay put together a very thorough information bulletin for the schools, and that included, well, the question was asked, has your school had CPR training? When did you last have CPR training? Would you want CPR training? And it gave them all the information that they required to move that forward if they wanted any CPR training. She also, we were on the run-up to Restart a Heart Live, so she sent out a lot of information about how to engage with Restart a Heart Live, and it certainly worked, because they were the second top council in Scotland. They'd 33 of their schools engaged on the day, so that was absolutely amazing. But on the back of that, what they then did was their fantastic technical people then got involved, and they mapped all the schools so we could actually see, looking at the Dumfries and Galloway map, all the schools on it, when they've had CPR training. Was it in the last year, last 2 years? Did they engage in Restart a Heart Live? And that's just a way to open up conversations. It wasn't to shame anyone that wasn't doing it, but more to open up that conversation. They can see, how do we get involved in this? So that's now public facing, which is great.
Brilliant, thank you both. Grab a seat, and can I invite Donald and Paige to come and join me? So we talked a bit about schools, we talked a bit about communities, a bit about the brilliant effect of having a local champion that catapulted Dumfries and Galloway to the top of the charts of engagement with Restart a Heart Live. And now we're going to talk a little bit about Good Sam and about cardiac responder schemes. So would the two of you like to, not that you need any introduction as to what organisation you work for, but do you want to just say who you are?
Donald McPhails, I'm the clinical effectiveness lead for out-of-hospital cardiac arrest within SCAS, and looking after Good Sam, or the response element, at least anyway, of Good Sam is under my remit.
And I am Paige Fletcher. I am the cardiac responder development lead for the Scottish Ambulance Service, and it's my role to look after all of the community cardiac responders volunteers.
So again, just hang on to that for a sec, Paige. So community cardiac responders. I wish we had more time to talk about them, but actually, Dumfries and Galloway have embraced this. Very rural council embraced this, and it's worked out quite impressively to start with. Do you want to just fill us in on what's been going on?
Yeah, so just to avoid any confusion, the community cardiac responders, it's essentially Wildcat on the move. So we know that it's been a great success in the Grampian area, and we know that it, in some areas, can improve the response times by up to 5 minutes, getting somebody on scene with a defibrillator and starting CPR prior to the ambulance crew arrival. So as part of the Care Zone project, we're looking to introduce cardiac responders across Dumfries and Galloway. October last year, I had the honour of going down, meeting with a lot of the council, and that's where this collaboration is working really well, because we're all working together. But we had 10 people sign up, and there's now 10 responders currently in the Glen Kens area, and they've attended a number of calls since October last year, and we have already actually had a success story and a really good outcome, a discharge from hospital following one of our cardiac responders being first on scene.
Brilliant, brilliant, thank you. That's, and it made the papers. Responders switched on, Good Sam, first shift, and within a couple of hours had a call and defibrillated someone successfully, so terrific. Couldn't have asked for better PR, really. Well done. And Donald, Good Sam is something we want to propagate, and we've heard a little bit about this already, started doing across Scotland. When it comes to getting a council to encourage folk to engage with Good Sam, what kind of approach are you taking?
So I've got access to all the data that we get from Good Sam regarding the number of people who are in any given area and who are being alerted and attending. And also then the types of person they are, as in when you sign up, you would say you're a first aider or a member of the community or firefighter or whatever you might be. So I can take that data and then incorporate into maps of a particular local authority, so in this case, Dumfries and Galloway, and then just use that to be able to just identify areas of particular need. I suppose in general, we need more Good Sam responders across the country, wherever you are. But in some areas, it probably makes more sense to focus efforts from a council point of view. So then, speaking with Gillian and her colleagues, once you're able to identify particular areas within a local authority, we can then tap into their knowledge of the groups that currently exist, where they might be able to have some input and impact to just help that promotion piece and be able to just describe to people within these particular groups what Good Sam is, the benefits of it, and just encourage them to sign up. It's not just someone from the ambulance service coming along saying, just come and sign this, it'll be great, but it's also their own council people saying, it's our community, you're out there doing work already voluntarily to help in your community, and this is something additional that you can do to assist.
Brilliant. Thanks, Donald. Thanks, Paige. Do you want to grab a seat? And Michael and Martin, do you want to come and join me? So really helpful there to hear about using what's already there in terms of responders, in terms of resources, people who might be able to sign up to Good Sam, and fantastic affirmation from Paige there about what happens when you pair the right solution to the right kind of geography with cardiac responders. So, Martin and Michael, thank you. Do you want to just tell us who you are?
Yeah, good afternoon. I'm Martin Ogilvie. My job in the council is the Resilience and Community Safety Manager, but I also chair the local Resilience Partnership.
Great.
And I'm Michael Hamjans. I am the head of ambulance services in Dumfries and Galloway, and I'm now chairing the tactical oversight group for the care zone in DMG.
Brilliant. Hold on to that microphone there, Michael. So part of the thinking around care zones is not just how do we start something up, how do we get people into a room, but how do we make it sustainable? How do we make it continue to develop? How do we make this into business as usual, something that will continue and not just be an enthusiasm which is here today and gone tomorrow? And these gentlemen are part of the mechanism that we're putting in place to do that. Michael, do you want to tell us about the Tactical Oversight Group, as you call it, which is a fantastic title for any kind of meeting? What is it and what does it do?
Yeah, so we basically took the care zone concept and formalized it into a tactical oversight group. And with the help of Martin and Gillian, aligned it to the Safer Community Partnership. Safer Community Partnership. And we've now got our own terms of references outlining our intent. We've got membership as well, so we now confirmed who needs to be in this group. We set our objectives aligned to the care zone levers. We developed a communication plan as well, and an action plan to how we achieve those objectives. And we are reporting, as I said, to the Safer Community Partnership. So it's our intention to report. So we only started this January, and after 12 months, or annually, we're going to report into this partnership, and hopefully to either get praise and encouragement to continue, or get some recommendation for improvement. So we basically have somebody to check our homework and continue progressing our objectives, I suppose.
Thanks, Michael. And can I just say, it's not a given that Scottish Ambulance Service would run that group, and thank you so much for putting your hand up to say you're willing to chair that tactical oversight group and be part of pushing this forward, which is terrific. And I just wanted to ask Martin, from your perspective, from within the council infrastructure, if you like, how does translating care zones into business as usual work from your point of view?
Yeah, I guess if you think back to that first S-curve, we were aware of projects that have maybe gone into that decline phase and the difficulty of keeping things going. So we had to embed this in a structure that was sustainable long term. So for a couple of years, we've had a Safer Communities Partnership that already does that for other important initiatives like road safety, water safety, antisocial behaviour, and safety at our large, big festivals and events that we have. So we have a structure, we have a partnership. We don't really care what uniform people wear, what headdress people wear, what rank people are. It's about the contacts and their knowledge. The council might chair half the groups, but that doesn't really matter. We've got fire officers coming in, ambulance officers coming in, police officers coming in. In Dumfries and Galloway, we've got a strong and long legacy of partnership working. It's a big area, but a small community, and we all tend to know each other and network well. So it was about drawing on that, building a sustainable and deliverable future that can take this initiative on and stop it going into the decline, and can be the forum for the next part of the S and the next part of the S, so we can keep on going from strength to strength.
Brilliant. Thank you very much. Gentlemen, do you want to grab a seat as well? And we'll just we've got a little bit of time for Q&A. I know that's been an absolute whistle-stop tour through care zones, but what I hope you've heard is care zones are hyper-local. They're, as Barry said, they're about a location. And we're going across Scotland, and one day we're going to get to your location, whichever council you live in, and we'll need your help when we get there. Care zones are about champions, local champions, like the folk who are helping with training at events or drumming up enthusiasm in schools for Restart a Heart. You could be those local champions in your area. Whether you're Scottish Ambulance Service, whether you work for a third sector organisation, Scottish Fire and Rescue, Police Scotland, whoever you work for. Care zones are about taking what's there in terms of people, in terms of community wealth, Gillian's called it, and in using that to help save lives after cardiac arrest. So the opportunity is coming for you to be involved in care zones, and we want you to be prepared and ready when that opportunity arrives. We've got just 5 or so minutes for any questions. I'm not going to ask all the guys to come and stand at the front here. I'll come down to here. But does anybody have a question for any of the huge brains trust that we've got at the front here who know more about care zones than anyone else in the world? Not a lie. Oh, sorry, wrong. Go on.
Thanks. It's fascinating. Thank you, Mike. Thanks. It's fascinating to hear about this stuff for someone who works exclusively in secondary care, and I'm interested to know and understand what's the measure of success of implementing a program like this? What objectives and what outcomes are the measure of the program?
We've as the program's gone on, we've sort of been developing a set of measures that we can measure success by. So it'll include things like the amount of things that are very easy to measure, like the amount of Good SAM sign-ups we have in specific areas, the amount of defibs that are within a certain distance of cardiac arrests, and calls that are answered by our amazing responder schemes. But also there'll be some like longer term measures, things like neurologically intact survival, ROSC, et cetera, that we won't really see in the immediate term, but we'll be looking to measure over the coming years. And that's why Care Zones isn't just like a strategy that you implement and you see the big ticket sort of items straight away. It's really embedding a new way of doing things in the long term so that we get those long-term positive patient outcomes.
Brilliant. Thanks, Barry. Any other questions? We've got one at the back and then at the front. Steve.
It's Steve again. This is going to be the next Scottish idea that I steal for Canada. So I was just wondering, and Gareth and I were speaking about this last night, can you give us any advice of how to get in the door at the council, how to get this on the agenda, and how to get them to believe that it's their problem and not the NHS?
I'll stand up. It's a hearts and minds issue. Tell stories. Tell stories and don't tell them that they have to do it. Ask people to help you with the problems that you've got. When Gareth indicated that only 1 or 2 or 3 people in my community survive an out-of-hospital cardiac arrest, and we could almost track that through the data, and I could see it on the map, and I knew people that I worked with that had been affected by this. I wanted to be involved. I knew I had skills, and I knew I had fabulous people that I could bring on who could help us do this as a community. So it didn't become a delegation. It didn't become a task or a part of a strategic plan. It became something that was really important for our communities to take ownership of. And I've said before, and I'll say that it's been the best thing I've been involved with all year. I've been in Dumfries and Galloway for 23 years. And to actually work with people, we talk about partnership working and we talk about multi-agency work, but we're really honest with each other, and we've got such a broad range of skills that we could pool together and make a difference at a hyper-local level. So don't tell the councils what they need to do, but ask for their help, because people want to help. They sometimes don't know how to help. And I think your sign here, I think, is really important. Give people permission to help, and they will.
Brilliant. Thanks, Julian. That's great. Amanda, do you want to add anything to that?
I suppose we just realise that every council is different. We've got an ageing population and a decreasing population, but we've still got 20,000 kids in schools. We've still got 78,000 households. And we need to think about the communications channels to get that right. So it's about a multi-channel sort of marketing campaign that is sustainable. And there's already some great national activity that we can piggyback. So big national events that we can use locally in schools. We can do, the council's got massive reach. We can put a leaflet into eldest and only children's school bags. We can put stuff on our council tax letters. We can put QR codes in all our buildings. We can train all our own staff. 25% of the working population of Dumfries and Galloway are employed somehow or other in the public sector. So how many people can we reach because we can sort of get them trained, get them talking about in the workplace that will go back to the households. I mean, I actually just moved out of Dumfries and Galloway last year to a town called Biggar that many of you will know, about an hour south of here. So in the last week in Biggar, every single shop, pub, restaurant, cafe that I've been to, there's now hundreds of these leaflets that cost a fraction of a penny to do. So it doesn't all need to be in social media and TikTok. It can be leaflets. And when I've asked in the places I've been to, they say that people are really interested. It's starting discussions, they're picking it up. There's all the information you'd expect on the skin, and on the inside there's a nice map of the village with the 7 or 8 defibs that they've currently got deployed. So with a town of 3,000 people, people know where the defibs are within 100, 200 metres off their house. You know, it will cost the council in Dumfries and Galloway pennies to do that for our villages and towns across Dumfries and Galloway. Thanks.
Brilliant, thanks. So some great ideas for engagement from Gillian, and 10 great ideas before breakfast for communication from Martin. That's terrific. Liam, you had a question.
Yeah, thank you. I think this is obviously a fantastic idea, and I'm already got the cogs thinking about how we can spread this UK-wide. I guess my thought is the ultimate thing we want to aim for here is to actually prevent the cardiac arrest in the first place, right? And so what's the next step in terms of bringing in the local health services to actually target those patients who are most at risk of having this cardiac arrest, and possibly even bringing in Ron from the secondary tertiary sector to go, actually, these are the patients that are most likely to come through my door. How do we start then reaching them to try and prevent the cardiac arrest in the first place with, you know, health promotion advice, et cetera, et cetera?
Yeah, that's a huge question. And I guess the logical direction of travel, isn't it, is to go upstream and say, you know, we want to get the community ready to respond before the emergency services arrive. And what you're challenging us to do is to think, well, how do we prevent people from having the arrest in the first place? I think a joined up health service would tackle that. I think it then falls, it's almost a bit the other project that comes before the Care Zones project, if you like. So absolutely needs to be done, but it's probably too big to fit into this remit. Harry.
Yeah, that was a great question. So something that I recently started, was a trial we did just 2 weekends ago, was a public health checks event. And I got a couple of local doctors involved, 4 paramedics, diabetic nurse, and we went and did a community health check event. It was the first one. I've been planning this for a few months. Normally we go out, we're doing CPR events, health awareness events. So this health check event I've been working on for months, and so the trial was two weekends ago. We had 80 people come through the door, and we didn't advertise it much because we didn't know, we didn't want it kind of overpopulated with the people coming in. And we had 3 defibrillators, we had doctors here. So with the 80 people that came through the door, 7 people we had to refer to the doctors for conditions they didn't know they had. And 1 person we had to send to A&E at that time, who was really ill. So this is exactly what I'm planning to do ahead, as well as CPR events, is go out in the community doing these health check events. And we are in talks now, well, early stages, to try and get external funding for that. I've talked to the doctors, and some of the doctors are friends and family. They said there is funding available that doctors get, GPs get, but they're not using it the right way. So we're going to try and tap in and see if we can get some of that funding diverted to us in the ambulance service, who has got the equipment, but we need the funding to go out and start. Since that event, I've had calls from Edinburgh, Dundee, Aberdeen to come out and do these events, and I was expecting that. So yeah, I think that is a way forward as well, you know, so just to kind of join on with what you're doing at the moment.
Brilliant, Harry, that's terrific. So apologies for my failure of imagination. Harry has presented at least part of the solution, and so that's a great idea of how we could possibly move upstream. That brings us about to time, unless any of you guys have anything. You look like you're bursting to say something, Michael.
No, I just want to say, so very similar to how Gillian felt, is although I'm in the emergency business for 25 years in D&G, I got really excited about this project because there's really some tangible evidence put in that we can make some improvement. It really felt like that. Ultimately, we obviously want to improve the cardiac arrest survival rates that were not going to be achieved within next year, 2 years, or before we can actually properly measure it. But with us setting these objectives aligned to the levers, we can actually measure it, and our preparedness for responding to cardiac arrest, this is something we can really measure. And it meant, Paige mentioned earlier that last year, towards the end of last year, one of the community responder groups who just really been introduced within the same day of same week. There's the first cardiac arrest positive outcome, the survival rate. And when this was shared within the group, although everybody only has a tiny wee role to play in it, there was really a buzz around this group. We all felt we had some part into the survival. And in that spirit, we want to continue it. And if we can save one more life, then it's worth doing it. But I'm very confident that going forward, we can improve our cardiac arrest survival rates.
Brilliant. Thank you so much. Thank you very much, guys. I mean, ultimately, I think the take home here is, it doesn't matter how good the plan or the strategy or the buzzwords are, the thing that makes the difference is this, the human capital that you've just seen on display, the enthusiasm, the relationships, the sense of purpose, and the willingness to get involved and try something that we haven't clearly defined, but we're defining as we go, but is making a difference. And thank you so much for that. So thank you guys for being willing to come. And I need serious self-control now. We've got a coffee break, which is, Dominica, how long? Oh, it says on there. Come back by 15:20. So you've got 20 minutes. Please go and see the sponsors, grab a cup of coffee, and be back by 15:20. Thank you. Welcome, folks. Welcome back. End of the last furlong, and we've got some very interesting stuff for you. The flash talks are coming, always a crowd pleaser. And then we have the world-famous Liam Saggy to close us off. You may have seen him on television. I have a job for you to do over the next 3 minutes, though. I want you to get your shift happened delegate badge thing and zap the QR code that says feedback and fill it in. And I'm going to keep talking for a couple of minutes while you do that, and I'm going to look around and give the evil eye to anybody I can see who's not manipulating their phone. This is really important for us. It's really important for a couple of reasons. One reason is, of course, we always want your feedback so we can improve and we can find out what you've found helpful and what's been less helpful. It's also super helpful for people like me and Vicky who are employed by higher education institutions, and that they want to tie whatever we do into some kind of feedback, and this helps demonstrate that actually people were engaged with what we were doing, and that's really helpful for us. So we just spend a couple of minutes. I don't think there are a huge number of questions. They've been carefully crafted. I realize that then Liam doesn't get included, but it'd be really helpful. Got my eye on David Bywater. I think when he's finished, then I'm assuming everybody should have had time to finish. Now he's cheating and asking the person next to him for the answers. We're just about there. Got long enough. What question number are you on, Dave? Great. Well, listen, you've made a start. Feel free to finish it off at your leisure. But let me introduce the other half of the dynamic duo that head up DH9. Leslie Hill. Leslie, coming up. And Leslie's going to chair us and take us through the last part of the day.
Well, thank you very much. As I say, I think I'm the last virgin on the stage. As I say, it's been a real honour for Roger and I to be here with you all today, and it's a pleasure to host this last session. And Gareth's been saying we're doing things a wee bit different this afternoon. So I'm pleased to host the flash talk. So we're going to just try and keep this moving along as quickly as possible. So I'd like to invite our 5 speakers, Susan, Vicky, Lisa, Diane and Stuart to come up and take a seat here at the front. They're each going to talk for about 5 to 8 minutes because there's been some debate over how long they're all speaking for. But they're going to do that, and we'll just move through these talks just really nice and quickly and take, if there's opportunity for questions at the end. So I'll allow you to each to introduce yourselves. Susan.
Thank you very much, everyone. So I'm going to speak to you today about Restart a Heart Live. Here we go. So yes, Restart a Heart Live is obviously the live stream event that we run. So where did Restart a Heart Live start? It started with an idea which came from the Scottish borders. Paramedic Lee Myers and his brother Liam and Michael Gardner, who came to ourselves with an idea of live streaming into the schools and the borders. And the Save a Life for Scotland partners have helped to make this now a UK event. So Restart Heart Live is not just a live stream, and it's certainly not to replace all the amazing CPR training that's going on in the schools, all the face-to-face training. But it is a very important part of the bigger system. So as we all know, the problem very well, an out-of-hospital cardiac arrest is an absolutely brutal, time-critical instant. So, you know, the faster that we can get people to recognise a cardiac arrest, put the call out for help, start CPR, and use a defib, then we'll obviously start to make a big difference. We already have in Scotland, over the last number of years, we've been building a system with all the Save a Life for Scotland partners, the Scottish Ambulance Service, Heart Start groups, your local community first responder groups, who are all out there doing training. We've also been working with the Scottish Government, and basically we're all trying to do the same thing. We're just trying to move that dial. And we've made lots of progress. As you can see from this, the partnership has already trained 1 million people. However, we do also know that the training that is going on out there is not evenly distributed. Some schools have got very enthusiastic staff who are very keen to have the children involved in CPR training. Some areas have got community first responders that are keen to be in their local schools. We've also got all the Save a Life for Scotland partners that are doing a great job. And also, you know, there's a lot of parents there that are willing to advocate for their children and say to the school, this is important. You know, please can, you know, the children have the training. However, there is a lot of children that don't get this opportunity. This is where Restart a Heart Live can bridge that gap. It's a terrible picture. So, Restart a Heart Live is a free national live stream event that brings CPR and defibrillator familiarisation directly into the classroom and communities all across the UK. It makes everything a little bit simpler because you've got no travel for instructors. There's no need to find trainers. And there's no need to find mannequins. So this is what it looked like last year. Pupils can practice in real time, just following the live stream. All they need is a cushion, a teddy, a jacket in a rucksack, and just follow what is on screen, so they can all get involved in this. So this CPR training is very much part of the ecosystem. As I said, it's not to replace face-to-face training. We're not saying you don't need mannequins, and we're not saying that a live stream is the same as face-to-face training. However, what we are saying, it's really important part of this ecosystem. And children learn in different ways. You know, some may enjoy the face-to-face, but certainly the feedback that we got from Restart Heart Live was they all very much enjoyed this. This was the results from 2025. We streamed on the 1st of October, and we had 132,000 people watch the live stream throughout the UK. So we know that cardiac arrest outcomes vary. Some communities face clusters of disadvantages. That could be health, geography, it's all the kind of stuff that we've been speaking about today, accessibility to training, and also the availability of public defibrillators. This is very interesting because, as you can see from the SIMD figures here, this shows that Restart a Heart Live was able to train 15% of the views of Restart a Heart Live were from SIMD1. Now that's the most deprived areas. These are the hardest areas to get into, and these children deserve CPR training as much as all the other ones. So we're really hoping to continue to bridge that gap. So why are we so interested in training schools? Because children change culture. They learn quickly. They ask questions, sometimes awkward questions, but they open up these conversations. So let's imagine that your primary 6 student has just watched Restart a Heart Live. He then goes home, he starts talking to whoever's in his house about what he's done. He starts speaking to the adults. Now all of a sudden, when they go out, they're noticing where their local defib is. And they're more aware of this. That school pupil in years to come may become a first aider. They may even join the ambulance service, become a paramedic. But they may also be the person that steps up when there's a cardiac arrest. So I've got a big ask for you. You can take your phones out again. If you take the QR code, the ask is, if you're a paramedic or involved in any kind of organisation, if you can think of your local school, it might be one that your child's at, or a niece or a nephew. On here, you can print off a letter and you can ask your school to be involved and give the children the opportunity to watch this. The other ask that I have from you is if you can share all the assets that we're going to put onto the website. So if you can share them on any bulletins, Facebook, any social media, we would really appreciate that. The only way that this is going to grow, and we're looking to train 1 million by next year, is by everybody sharing this and encouraging schools, communities to get involved. I'll finish with this. An out-of-hospital cardiac arrest, we often speak about gaps. You'll hear it all the time. The gap between the person collapsing and recognition. And then we talk about the gap between recognition and CPR starting. and then CPR starting, and the defib arriving, and the defib being placed. We're always talking about those gaps. Restart a Heart Live isn't a solution to all of these gaps, but it's a practical, scalable, low-cost way of closing them. It gives families a conversation. It allows children to act. So before you leave here today, if I could ask if you can all think of one school, it could be a school that's in your local vicinity, and if I can ask that you just contact them and just give them that wee nudge, just to say, do you know about this? You can print off the letter, give them the QR code. If we could ask everybody just to get involved with one school, that would be great. Or you can get involved in as many as you like, but that would be amazing. Thank you very much.
Hello, I introduced myself earlier, but in case anyone wasn't here, I'm Dr. Vicky Joshi. I'm a research fellow at Glasgow Caledonian University, and I kind of look after the South Recovery Group. Now, South Recovery wouldn't exist without all of the amazing work that you do, because we wouldn't have any survivors to be thinking about. So I think South Recovery, by the sounds of it, all these amazing projects and things that are coming, hopefully what we're going to have is more work to do in the future, because we're going to have more survivors. I'm just going to give you a little kind of update on some of the things we've been doing in the last year, and a little reminder about what we do in South Recovery and who we're interested in. So survivors, really obviously. If you've heard me talk before, I'm listening to Ron and he's talking about the 22-year-old that was discharged and everything's great, and I'm thinking, ooh, I wonder how his brain is. I wonder how he's feeling. I wonder what he's thinking about having an ICD now. I wonder what he's thinking about having all these shocks or not having a diagnosis. I'm also wondering, who did the CPR? What were his family thinking? You know, how do they feel? They were maybe, again, how does it feel to have a family member that doesn't have a diagnosis? You know, fear for the future. So we're thinking about the survivors, we're thinking about the family members, bystanders as well. And of course, because we have many more people, unfortunately, that don't survive, we often have many more bystanders who've done CPR where the person hasn't lived. And then they're not in contact with any kind of services afterwards. So we maybe have many more bystanders than we do have survivors. On that list also is volunteer responders. So CFR, I've talked to so many of you today, and it's amazing. And thank you so much to Lisa and the Newtons to really highlight the work of that. But that's a group that we need to be thinking about as well, I think, in South Recovery. And then we have the healthcare professionals, the EMS, you guys. And again, it's not something we've done a lot on yet, but we are aware, particularly maybe when you are maybe involved in events or doing CPR outside of your normal role or outside of your normal working hours. Of course, we're all willing to step up, but actually looking after you afterwards. So what have we been doing? Well, quite a lot around information. So something I often say is if you've had a stroke, nobody's surprised that you might have something wrong with your brain or you might need support or rehabilitation afterwards, but it's not something that's commonly known after cardiac arrest. So we've been working really closely with the Resuscitation Council to produce new information that we're hoping, this is a really simple leaflet, it's really just giving the beginnings of information and some signposting, hoping to get that into the hands of every cardiac arrest survivor and their family members. We've also got new resources on the NHS Inform website. So again, one place where people can go, get all the information, and then the signposting to other organisations. If you are interested in getting the leaflets, you can follow that QR code, and I think they are free, and they're certainly free to download, but the paper ones, I think, just paying for postage and packaging. So, and then that's a QR code that will take you to the NHS Inform website. Research, also vital. I would say that we are still quite a long way behind in terms of other kind of long-term conditions. In terms of cardiac arrest, we still have a lot of gaps in our knowledge about what the key priorities are for cardiac arrest survivors and how we can deliver aftercare. So I'm very pleased to say we've been funded for a 3-year research project funded by the Scottish Government called Carousel. I know, I do like to name things and have nice logos. I could talk all day about what we're going to do with the Carousel project, but at the heart of it are a series of studies that will tell us who our survivors are in Scotland, where do they go. We're going to follow them through using the SCAS out-of-hospital cardiac arrest data. We're going to follow them through the routinely collected health data. Where do they go? How long are they there for? Who are they coming into contact with? We're then going to follow a group of survivors and their family members in a quite in-depth way through questionnaires and through interviews at 4 time points after their cardiac arrest, up to a year post-cardiac arrest. The idea being that we can really then identify what are the unmet needs, where should our intervention be, who should be delivering it, and what are the priorities. So at the end of it, we're going to be doing some work with clinicians, people like yourselves, to then design this aftercare intervention. And also think about what's it going to cost, who's going to deliver it, how are we going to implement it. Just thinking about bystanders, I can't stand here and not talk about the bystander advice line. We're so lucky that Chest, Heart and Stroke Scotland support this. Hopefully you've all seen these pink cards. These are the pink cards that are hopefully given out at the scene of a cardiac arrest. I know there's been a new project that Shorty's been delivering for the cards to actually sit in the drug pouches. So the idea is when you open them up, they almost kind of pop out or fall out. We know there's a lot going on at the scene, so we do really appreciate the fact that you are giving these cards out. We know that they're being given out because that's the main way that people are coming through the advice line. We've had 308 contacts, mostly telephone calls, since I think it's about 2.5 years that the project's been running. And what we're also seeing is a year-on-year increase in the number of contacts, the number of calls as well. So we are 27% up on the last year to the previous year. And again, so much of that is to do with the promotion, all right? Again, it's not common knowledge that if you do CPR, if you're a bystander, that you might actually need someone to talk to afterwards. So half the work with this project is getting that message out there. Again, what are we doing next? What are we thinking in terms of bystanders? We met last week at the race meeting, another natty name and logo, I know. Recovery after cardiac arrest, again supported by Chest, Heart and Stroke Scotland. All the people that you see there are really passionate about bystander aftercare, looking after the people who stepped up and done CPR. Some of the things that we're thinking about is what can we do at each stage of the chain of survival to reduce the impact on bystanders? Not affect survival, but are there things that we could be doing to just reduce that impact on bystanders? Access to information, communication and support, and the right support at the right time. So something we hear from bystanders is they do want to talk to someone, and we recommend that they talk to someone, but it can be pretty tough having that conversation with a friend or family member or co-worker. So having somebody independent to talk to through something like the CHSS advice line seems to be really important. One of the other things we're thinking about is when we talk to bystanders, can that help inform what we're doing at the beginning of the chain and thinking about the way that we teach CPR? So that's a bigger project that we have ongoing. So I'll come back to my first slide. I would say that we're doing okay on the survivors. Okay, there's still a lot to do, but we've made some good inroads. Again, family members, that kind of goes hand in hand. And we are making some good inroads with the bystanders. But I will be honest, Self-recovery is a very small team, and we haven't really started looking at volunteer responders and healthcare professionals. So what I would say is there is lots and lots to do. So if you are interested in any of the things that I've been talking about, please do get in touch. There are lots of questions to answer and lots of, I think, quite simple ways that we can be solving some of these problems. So please do get in touch, even if it's just a case of you want to maybe offer your expertise or your experience, maybe be involved in a focus group or something like that, or you're actually thinking, I'd quite like to get involved in the research. Okay, I'm going to stop there. Oh, I forgot to say, these are just some of the groups and institutions that help out with self-recovery, and I'm really glad that Chest, Heart and Stroke Scotland and Southern Cardiac Arrest UK were here today as well, so a big shout out to them. Right, it's me done. Lisa.
I've got this. Oh, I don't know what. Almost forgot I was speaking there for a moment, actually, sorry. Okay. Got 8 small minutes to talk to you about this, but I want you just to think a little bit about why you do what you do when it comes to out-of-hospital cardiac arrest. What's your passion? Well, mine really is about working with people and working with communities to be able to empower them to actually take stuff into their own hands and make things work in their own communities. And actually, if I dig down a bit deeper, the stuff that really gets me passionate is about those people who we know already are still at the sharp end when it comes to survival from out-of-hospital cardiac arrests. And they're the people who live in the areas of deprivation in our beautiful country that is Scotland. So let me just dive in and ask you this question. If Scotland already has thousands of pads, why are those living in deprived communities still less likely to use them? We heard Andy talk at the top of the day about the great stuff, the strategy that we already have in Scotland. We've got data, we've got the strategy, we've got Save a Life for Scotland, we've got Good Sam, we've got the circuit, we've got CPR and defib training in schools, and we've got Scottish Government support in terms of funding, who want us to be able to put defibs in deprived areas, those areas that really need them. So we seem to have the system in place, but it just doesn't seem to be completely working for everyone. If we've got the system, why aren't people who are living in areas of deprivation using pads, and why don't they feel ready to use them? So I've taken a little bit of time out just to do a little bit of a deeper dive into the literature that kind of sits around pad use. So not even just looking at deprived communities, but really why do people use pads and why don't they? What puts them off? And if people have tried to get people to use pads more, what have they tried to do? What worked and what didn't work? And it's been really interesting. When we look at Scotland's data, the feeling is, or if we don't look at Scotland's data, the feeling is actually if there's more cardiac arrests in deprived areas, let's just give them more pads. But when we look at Scotland's data, there's a similar amount of pads in SIMD1, the most deprived areas, as there is in SIMD5, the most affluent. So it doesn't really seem to be about the fact that they don't have enough pads. It seems to be that there's still this gap in outcomes, and it might actually be about readiness rather than numbers. So we really need to know why they're not engaging equally. So looking at the research, when we look specifically at barriers, none of this will come as a surprise to you. Across numerous countries, numerous contexts, numerous communities, there's 3 main things that come out of it that are big barriers, and they're not technical, they're human. First really is about self-efficacy, and what that really means is, have I got the confidence to do it? Am I the right person? And we see this in CPR as well, people who just step back and think, actually, there must be somebody who's much better at this than I am, so I'll let them do it. And the second is fear, and we all know what that feels like. That fear of harm, of judgment, of legal consequences, that fear that we might look stupid in front of other people who are there. And then you have legitimacy, which is slightly different from self-efficacy. It's that I want to do something, but actually, am I allowed to do it? Is there something in that environment or the people around about that's putting them off? And when you look across these studies, what's really interesting is that there's this consistent thing, that when you look at people who live in areas of deprivation, the fear, the lack of confidence, and the lack of that feeling that they've got authority to do something is consistently higher. And that's really people who have got less educational attainment, people who feel that they've got less social power, and people who've got less training. So we're all in the same boat. These problems are just harder for people who live in deprived areas. And as I looked more at the data and at the papers, realized it wasn't just like human barriers. We have some real structural barriers, and you know this already. Defibs in cupboards, getting dusty, behind desks, locked away in boxes outside, inaccessible 24 hours a day. An invisible pad, to me, is almost the same as no pad at all. So on top of these human factors, we've also got these real structural factors. But physical invisibility and social invisibility are two separate things. So you can kind of fix physical invisibility. You can put a sign on the wall. You can take that pad out the cupboard and you can put it in a box outside. But social invisibility, you can't fix with a sign. You could say a sign that says, please use this is yours to use, but we don't do that. We just say it's a defib. So what interventions have people tried across the world? Well, I just want to share 3 examples with you. The first was in Singapore, and they have used a smartphone responder system and put lots of pads out. Did a bit of mass marketing, and they have increased their pad use 4-fold. Another really interesting study, slightly controversial in Italy, this project's been running for 23 years. And instead of teaching people how to do CPR, they teach them how to use a defib. And they have about 150,000 volunteers, loads of defibs, and their ambition is to get pinged by a smartphone, get the defib, take it to the person, and shock them in under 5 minutes. And they don't do any CPR at all. They've got a 46% survival rate in that area. They've taken the fear and the whole technicality of chest compressions out of the equation for lay members of the community. Controversial, but something to think about. And then in Denmark, well, Denmark, we know, just like throw the whole kitchen sink at stuff. So they used mass marketing. They trained loads of people. They put loads of defibs out. And over a whole year, the people that they trained in their communities had a real increase in willingness to use a defib on somebody, and especially a stranger. The things that worked, well, when you just put defibs out and give people information but don't engage with them, they don't work that well. It's not rocket science. If you engage communities, talk to them, find solutions with them, then those interventions are much more likely to work. But the thing that stuck out for me from all of this is this just huge lack of studies and interventions that have not been done in deprived communities, where we know that cardiac arrests happen the most. They're all just generalised. And there's hardly any studies or work that's been done that's been co-produced with communities who are most at risk. From this work, we know what works, but we don't know if it works equitably. And we don't know how to make it work equitably. So we might be really good at building pad infrastructure, but we don't fully understand how to build pad readiness for the communities that need it most. And we've got a responsibility as people who care about this stuff to make sure that the communities that need it most get the most attention around us. And I think it's not rocket science. The people in these communities know what it feels like to be in an emergency situation. They know what it feels like to feel unsafe. They also have solutions, but they also know what kind of words, what kind of methods we use that will completely put them off. So it's really important that we're the ones who sit down with them, share this information, tell them what the outcomes are for their communities, give them some options of what's tried before, and work with them. Because a pad doesn't save a life, a person does. And the people who live in deprived communities are the same as us. It's just that learning how to use a defibrillator is not top of their to-do list for that day. People are dying in these communities who do not need to die. And we've got a good system. But whether that person acts in that time, in that community, in that emergency, will depend on whether the system was ever really built for them. So my challenge to all of us today is let's sit down with them. Let's co-design and produce a system that works for them. Thank you.
Thank you. I was told we only get 5 minutes, so I put in a lot of effort to get my talk down to exactly 5 minutes, which is completely unnecessary. Since there's a little bit of time, I'm going to introduce myself. So my name is Diane, and this is my first time at SCAS. Gareth has asked me to do a flash talk in previous years, but I was busy getting married last year, and the year before that, I was on holiday, but Gareth caught me this time. I used to work with Gareth and Dominica and Susan at the Resuscitation Research Group and Save Life for Scotland. I actually worked on the PadMap tool that has been launched, but I have since left to do my PhD related to defibrillators. Oh, why does it look like that? I am someone who's really proud of my slides, and they're not supposed to look like this. So that is very disappointing. So I'm going to start my talk with something that's going to sound a little bit controversial. I think innovation is overvalued. And don't get me wrong, I think innovation is important, but I have a bone to pick with how we talk about innovation and what gets left behind in those conversations. Again, it's not supposed to look like that, but that's fine. So one of the scholars who has really influenced my thinking for my PhD research is Stephen Jackson. And in his essay, Rethinking Repair, he argues that our society obsesses over innovation, while maintenance and repair gets treated as secondary, something that is less visible, less valued, and something we only think about when something fails or breaks. And I feel like this argument is also very true for what we tend to see in out-of-hospital cardiac arrest systems and what we see in resuscitation research more broadly. So we love talking about innovation within out-of-hospital cardiac arrest. Here are just a few examples related to defibs. We have drone deliveries of AEDs. This has attracted significant research attention and funding. We have mathematical optimization models for pad placement, and the PadMap tool is an example of this. We have citizen responder apps, and in the UK, we use GoodSam, primarily for bystander CPR, but in other parts of the world, they also use these apps to deploy pads as well. To be clear, I do think that these are all interesting and exciting developments. However, innovations in this space tend to assume something that is quite fragile. And that is that the defibrillator is actually functional, available, and accessible when it is needed in an emergency. But the reality is that is often not the case. So in my PhD research, I've been learning a lot from pad guardians, and I've been mapping out the life cycle stages of a pad. And what has become increasingly clear is how truly fragile the infrastructure is. Currently, I've mapped out the life cycle as the 6 stages, acquisition and installation as 1, registration, routine maintenance, deployment, post-deployment, and transition. So at every single stage, things can and do often break. That stops a pad from being able to fulfill its life-saving potential. So for example, a pad can be installed but never gets registered on the circuit, or guardianship is not established or sustained over time. So we have things like the device getting neglected and we get dead batteries, expired electrode pads, etc. We have many cases where a pad gets deployed, but then the device goes missing afterwards for days or weeks. So behind every pad that has been able to save a life is a pad guardian who is continuously doing the unglamorous work of maintenance and repair in the background. So guardians are the ones who are performing routine checks, replacing consumables, fundraising, encouraging registration. They're chasing down these missing devices. They're also reporting data inaccuracies on the circuit while also supporting other people to maintain their devices. This is just a few examples of this hidden labor that they do. And this essential work is largely shouldered by volunteers, as we know, and without them and their labor, this whole system collapses. So maintenance and repair looks like nothing when it's working well, and that's a problem. So if we want to improve survival outcomes, we need to start giving maintenance and repair the same attention that we give innovation. And we can apply that lens to innovations that we've talked about at SCAS today. So when we think about citizen responder apps like Good Sam, it's not just about uptake numbers, it's about how do we sustain engagement in 5 years' time. When we look at optimal placement of pads, which is a big thing for Scotland right now, it's not just asking where should we be putting them, but who is going to be taking the responsibility for maintaining them in an emergency-ready state over time. So I have a paper that's been accepted and coming out soon that goes really into depth about all of the hidden labor that pad guardians do and all of the creative solutions that they implement to get pads able to save lives. So give it a read when it is available online. Lastly, I just want to advertise that I am starting to recruit for my second study, which will be focused on how can we better support the work of pad guardians, and also how do we move towards more resilient and sustainable models of guardianship. So if you are a guardian or know someone who might be interested, feel free to contact me via email or scan that QR code and you can send me a message and yeah, get in touch. Thank you for listening.
Afternoon, I'm Stuart Gillen from the Royal Intensive Care. Thanks very much for the opportunity to speak. So cardiac arrest is a difficult disease to survive, and that's particularly true if the cardiac arrest does not resolve with the initial management, defibrillation, CPR, ALS interventions. And no matter which way you cut it, the longer that that individual is dependent upon chest compressions to maintain their circulation, the less likely it is that individual will survive their cardiac arrest and subsequent hospital admission. And that's true even for those patients who start out with relatively favourable markers, the patients who have an initial shockable rhythm. Now, these aren't the patients whose cardiac arrest is the consequence of a progressive disease. They're not the patients who are dying. These are the patients who are walking to work, who are playing squash, who are driving a forklift truck when they collapse. These are the patients who the problem is an isolated heart problem, and it's usually a problem that we can fix. We take them to the cath lab, the cardiologist open the coronary artery, or we deal with their complex rhythm disease. The problem is that we can't often get these patients to the place that can fix it while they're still alive. And the challenge is trying to find a way of keeping these patients alive long enough that we can fix the underlying problem. And you can see even for those patients with a shockable rhythm, by the time they get to 20 minutes, 30 minutes of ALS, the chance of a good outcome is approaching zero. The answer for some patients may be this. So ECMO, extracorporeal membrane oxygenation, is a pretty simple medical device. It's a pump that draws blood out the venous system. It's an oxygenator that puts oxygen into that blood and then returns it back into the arterial system under pressure. And it's a form of cardiopulmonary bypass. It's similar in principle to the heart-lung bypass machine that's used in cardiac theatres. The difference is it's portable, it's easily deployable, and you can do it without having to open the chest. You can do it through peripheral blood vessels. Now, ECMO's been around for decades, and the idea that it could be used in refractory cardiac arrest has been around for decades as well. But the interest particularly kicked off about 6 years ago when this paper was published in The Lancet. Now, Dimitris Yiannopoulos and his team in Minneapolis, which I didn't, until I said it, realised that that rhymed. He randomised a group of patients who presented with a VF cardiac arrest who did not respond to the first 3 defibrillations. They moved those patients to an appropriate hospital and they randomised them to either continuing with conventional ALS or establishing them on ECMO to support the circulation. For those patients, and sorry it doesn't project very well, but for those patients who were in the conventional group, all of those patients died. Now at the time of randomisation, they were 45 minutes into their cardiac arrest. For those patients who were entered into the ECMO group, over 40% of them were alive and neurologically intact at 6 months' time. So this is a technology that works in principle. The difficulty is getting it to work in practice. Because although using ECMO in the context of cardiac arrest buys time, it's not an infinite amount of time. And for it to be successful, the patients need to be on within the hour. The sooner the better, but at an hour things start to go downhill fairly quickly, or outcomes go downhill fairly quickly. And so for this to work, it needs to work within a system that can get patients onto ECMO within 60 minutes from the point of collapse, which for those of you who work in the environment where you're trying to get the patients to hospital in that time, will know that's no mean feat. And we found that when we tried to do this a few years ago in the Royal, that's what the tarmac in the Royal, outside Royal ED looks like. Most of you will never seen that tarmac before. I'm not sure who got this photo when there was so few ambulances about. But we tried in the Royal to get patients into the patients in refractory cardiac arrest into the emergency department quickly enough that we could establish them on ECMO. And despite the very best efforts of everybody involved, it was very, very difficult, and very few patients met the time criteria. So we did a bit of modelling work, and we took data from the ambulance service database and looked to see where these refractory cardiac arrests were happening. And we looked to see how we could do it differently. And we looked at various different models. We looked at trying to set up a service within different cardiac surgical centres or cardiology centres within the country. And then we looked at potentially deploying a team pre-hospital to establish patients on ECMO in the field. And the graphs there are fairly busy, but what they demonstrate is that if, with a single team based in the central belt of Scotland, a number of patients could be reached who at the moment are in and remain in refractory cardiac arrest and die. And the number of lives saved could be in the tens over the course of a year. What we'd like to do is to move that from a theory into a practical pilot to determine whether it can work, whether it is feasible, and whether this is something that Scotland could embrace as another adjunct in the effort to save lives of patients who are in cardiac arrest. And we are working collaboratively with a number of bodies across the country to see if we can put that pilot in place. The primary body in this, as you can imagine, is the ambulance service. You're the people who see this, who recognise the problem more than anyone does. And Health Improvement Scotland have recently got involved, and they are offering their analytical expertise in evaluating the technology to begin with, and then the output from any pilot study. And there's been provisional conversations with the territorial health boards who would provide the ongoing care for these patients. because the ongoing care would have to be delivered in one of the cardiac surgical centres within the country. The other major step which is coming is the publication of this trial. The Dutch have been doing a randomised control trial which is trying to ask the question not does ECMO work, but can ECMO work in a practical sense? And they are expected to publish their results in the New England Journal within the next couple of months. If that comes back positive, I think that shifts the landscape even further and demonstrate this is something that healthcare systems should be moving towards. So the token AI generated image is that this is the vision, that within the near future that we collaboratively bring to pilot stage a pre-hospital ECPR service that can be deployed to those patients who present in VF or VT, who we can't get back into perfusing rhythm using conventional measures. Thank you.
So thank you very much to our 5 speakers there. Some really interesting and quite amazing work that's been going on. Have we got time for questions? No, we've not got time for questions. So catch them on the way out, but I'll just finish off and thank you.
Thanks very much. Well, every year this time at SCAS we have the final speaker to give what's been known as the call to action talk. And today is no exception. We have Liam Sagi, who is going to join us in a sec to give us the final talk of the day. And I hope as Liam comes up to join us that when you reflect on the day, you have not just been entertained, not just been given some additional information, but actually been provoked. Provoked to think about that one school that you're going to send a letter to. Provoked about thinking about how you can get involved in care zones when they arrive in your part of Scotland. And if, as you reflect on this, please take your badges away, look at the QR codes on the back that will help you engage with some of these things, and then share it with somebody else who wasn't here today. All of the talks will be up online at scas.scot in the next few days and weeks, so you can go back and you can encourage other people to go back and look at anything that was particularly interesting. But without further ado, Liam.
Good afternoon, everyone. Just a couple of things before we start. Can I just say thank you to Gareth for inviting me to talk today, and can we all just give a round of applause to everyone that spoke today, everyone that's put the effort into making this conference happen. It happens for free. Don't underestimate the amount of effort that goes into delivering that. So just a round of applause for everyone, please, before we crack on. I really wanted to feel like I was in the kind of SCAS, mode. So I borrowed this t-shirt earlier on, and there are 2 things wrong with it. One is that it's a bit too small, so apologies for that. The second thing is I appear to have dressed like a slightly tall Oompa Loompa. So enjoy that if you watch this talk back and reminiscing that I should be with Willy Wonka somewhere. I want to take you all back to 2016 in Scotland. So just have a little think about that, and for some of you that will be easier than others. But let me help you by showing you a few things that might remind you. The Apple iPhone 7 was the phone to have. It had just come out. That's the thing you wanted. The Ford Fiesta was the top-selling car in 2016. This song was #1 for most of the year. Or not. Oh, we've missed it. I mean, I don't like this song personally, and I'm not doing a rendition of it. It's Drake, One Dance. Feel free to go listen to it on YouTube later. Believe it or not, this drink, which you've already seen, was rapidly heading towards one of the top 100 drinks selling in the UK. That is not a lie. Feel free to have a look at it. And ambulances looked like this in Scotland. And I'm not entirely sure, I think England beat Scotland in the Six Nations that year, but I'm not entirely sure. Don't worry, I'm partly Scottish. And to really think about the 2016 conference that year, which was Shift Happens. I'd like you all to just stand up for a second, please. Don't worry, it's not long till you'll get your Buckfast. Okay, so in the true spirit of Shift Happening, you've all just had an out-of-hospital cardiac arrest. I'm sorry about that. In 2016 in Scotland, if you had an out-of-hospital cardiac arrest, less than half of you would get bystander CPR. So if I could just ask the whole middle section to sit down, please, because unfortunately, you probably haven't survived because you didn't get any bystander CPR. Of those, there's about 120 of you in the room, okay? So bear with me on my maths here, this might not be quite right. About 25% of you will have a shockable cardiac arrest at that point, okay? Now, that equates to about 30 of you in the room. How many of, let's take this side of the room. There's about 30 of you. How many of you would like a defibrillator for your shockable cardiac arrest? Put your hands up. Yeah, most of you, yeah, I think so. Well, the good news is 3 of you will get a defibrillator, which means 27 of you witnessed no defib will probably die. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Maybe everyone apart from the last 3, 4 rows, sit down, please. Unfortunately, you've died. That leaves approximately 33 of you left in the room. 24 of you will get ROSC on scene, which means probably another 9 of you have died. So Shorty's row and the row in front. Let's see these guys here. Might have overestimated the pudding here a little bit, but we get it. Okay, so it leaves a couple of you over here. Let's say there's 24 of you over here. Around 15 of you, of the 24 who got a ROSC at scene, will unfortunately die at hospital, which you look like 15, don't you? You can all sit down. So here leaves 1, 2, 3, 4, 5, 6, 7. I've been a bit harsh, 7 of you. Actually, 9 of you in 2016. So this many people in 2016 would survive their cardiac arrest in Scotland. Now, that's not great, right? You can all sit down. You've gone home neurologically intact, hopefully. Okay, so shift really does happen, right? But then you got your shift together. Then COVID happened, and you realized it was deep shift. And there was shift to do to fix it. And here we are recognizing that shift happened. But actually, what shift did happen? We went from less than 50% of you to 66% of you getting bystander CPR. More than 3.5 times more people will get a defibrillator applied to them having suffered their cardiac arrest. Instead of, sorry, that's meant to be, 1/4 of it, you'll get a ROSC instead of 1/5. That's shockable and non-shockable, don't it? Or vice versa. And for survivors, you've gone from 7.6% to 9%. Now, not a massive fan of the percentage. What that looks like in terms of per million population is from 44 per million population to 61. Now, I suspect most of you already know this, right? That's why you're here. You've been involved in this for the past 10 years. And we've made improvements. We've seen more people doing CPR, more people getting a defibrillator, more people getting ROSC, more people surviving their cardiac arrest. And this is fantastic work, all right? We should celebrate that. But it's not done, and we need to keep shifting. The question is, how do we keep shifting? Gareth, you're free to use keep shifting for the next SCAS, by the way, but I don't know if it's probably doesn't fit the rhetoric quite much. Now, this is where it gets a bit cheesy, so please bear with me. What I want to do is tell you what I think shift means, and importantly, I want to talk about each element of shift. And when I'm talking about these, I want you to think about what it is you do and how you can contribute to those individual elements of the shift. So here's the first one. Stay focused. Again, I don't need to tell anyone in this room to rest on their laurels. We've made incredible improvements, we've made incredible progress, and we should celebrate those. But we do need to focus on what we do next. In a system that's as complex as cardiac arrest care, it's easy to feel like what we do is just one small part, okay? But every part matters. And your part, your decisions, your actions, your standards, contribute directly to someone's chance of survival. What you already do matters, the way you teach, the way you lead, the way you deliver your care, the way you support others. That all matters. It's the foundation of a system as it stands today. But staying focused isn't just about continuing what we do and doing it well. You've got to ask a little bit more of yourselves. The biggest gains in survival won't come from one breakthrough moment, okay? It'll come from thousands of tiny decisions made by people like you choosing to do things just a little bit better or a little bit different. And those things add up. Keep doing what works, that's essential. But like Professor Lockie said earlier, we've got this ceiling at the minute of 10% of cardiac arrest. It doesn't have to be the ceiling. Look what you could do better. Be curious about it. Act upon it. Because the truth is, none of us can change everything, but every single one of us can change something. And when each of us makes that contribution, every time just a little bit more, that's how the system evolves, and that's how cardiac arrest survival improves. There's no pun intended in this one. Keep the patient at the heart of everything you do. It's easy, it's almost inevitable, to become focused on the system. The metrics, the protocols, the figures, the rates of survival, and sure, all those things matter, right? They're essential, but they're not the reason we're here. At the center of all of this is a person with a life beyond their cardiac arrest, a family waiting, often without knowing that their life is about to change, a community that may or may not have had the opportunity, the education, or the confidence to act, and in fact your colleagues standing beside you, doing their best in some of the most pressured moments they'll face to save someone's life. Keeping people at the heart of what you do means constantly reconnecting with that reality. The system is crucial, but it's not all about efficiency. Of course, the time to CPR, the time to defibrillation, and advanced resuscitation, it's all important. But patients and their rescuers need care in the context of their life. Care that reaches them where they are. Care that reflects their community, their access, and their understanding. Care that doesn't unintentionally exclude. So don't just keep patients at the heart of what you do. Keep the core survivors, someone's doorbell, the rescuers, the emergency responders, the aftercare teams, and the communities central to every bit of work you do. And keeping those people at the heart of your work isn't a passive thing, it's an active thing. We probably have more understanding, more evidence, and more data than we'd ever had about how this contributes to your chances of everything. Your chance of education, your chance of survival, your chance of CPR, all those things that we already know. But it's not because the science is different, it's not because the treatment is different, it's because the access, the opportunity, the education, and the support are not equally distributed. And if we're honest, that hasn't happened by accident. That's happened because somewhere the system has failed to reach these people. And we also know that that shouldn't be the case. Who isn't in your teaching session? Who isn't represented in your community engagement? Which areas don't get the same focus, the same resources, the same attention? And then the harder question, what are you going to do about it? What am I going to do about it? So whilst you're staying focused, keeping the patient at the heart of everything you do, and think about all of that, and how do you reduce the inequality in all of that? We make it fairer, we make it stronger. Diane might disagree with me in the innovation bit here, but if we want to improve survival, we need to think differently. And we need to innovate. We need to challenge where we are today and be willing to move beyond it. Now, I'm slightly biased, right? So I think the next bit for us as an ambulance service is video. Gareth, get video in Scotland, please. Because the reality is we've worked really hard over the years to strengthen the chain of survival. We've refined it, we've improved the processes, we've standardized the care. It's made a difference. But we've put in a lot of effort, and we're still only seeing marginal gains. For what we've been doing, we should be seeing massive change. And that, for me, tells us something important. It tells us that doing more of the same, no matter how well we do it, is unlikely to get us truly where we want to be. So we need to be one step ahead. Technology is evolving around us at an extraordinary pace. And within that, there are opportunities that are only just beginning to tap into. Opportunities to improve how the public, or even your smartwatch, recognizes cardiac arrest, how they act quickly, how we educate and train at scale, how we respond, how we deliver care, and how we support the rescuers after that event. The potential is huge, but only if we're willing to engage with it. And that starts with mindset, being bold. Challenge the norm that you've become comfortable with. question the things we've done because we've just always done it that way. Innovation doesn't come from staying within the lines. It comes from people willing to say, do you know what, maybe we should try this a bit differently. And those ideas might feel unrealistic at first. They might feel too ambitious, too complicated, or even impossible. But those are exactly the ideas that we need to hear, because somewhere in that thinking, somewhere in those conversations, could be the key to unlocking the next step in improving survival. So don't hold back. Use your imagination, bring out your ideas forward, and start conversations that push things further than they've been before. You can do all of those things I've mentioned, but if you do it by yourself, you will not get very far. Everything we've achieved in cardiac arrest is built on a system, a complex, interconnected, high-performing system, and no one person, no one team, no one organization can make that system truly effective on their own. It only works when we work together, across services, across discipline, across traditional boundaries, from the community to local councils, to ambulance services, to emergency departments, to the critical care units, and beyond. But togetherness isn't just about the people already in this space. If we're really serious about improving outcomes, we need to go further than that. We need to bring people in who aren't already engaged. People who you wouldn't expect to be engaged. Mathematicians, people who make buildings, all that kind of thing. Because cardiac arrest isn't just a clinical problem. It's a public health issue. It's a community issue. In many ways, it's an emergency that started way before we even arrive. So togetherness means widening that circle. It means working with communities, not just for them, but with them. Connecting with schools, education, local leaders and organizations. It means building partnerships to strengthen prevention, improve education, and support people before, during, and after cardiac arrest. But importantly, it means joining it all together. Not as isolated efforts, but as one coherent, connected system. A system that prevents where it can, responds effectively when it must, educates continuously, and supports compassionately. And keep the patient at the center of that throughout. This kind of system doesn't happen by chance. It's built intentionally by the people who choose to collaborate, to share, and to bring others with them. That's people like you in this room. So let's keep shifting, but don't do it in isolation. Do it together in collaboration, true collaboration and partnership with a shared purpose. Because that's how we build something stronger than any one of us alone. Before I finish, I want to introduce myself. Now, most people do that at the beginning of their talk. But to be honest, it doesn't really matter who I am or what my background is or what my experience is. I'm not better than any one person in this room to contribute to changing someone's chance of survival from cardiac arrest. My background is an advanced paramedic, a job that's exposed me to time and time again patients needlessly dying from out-of-hospital cardiac arrest because they just didn't have one thing that they should have had at some point in their chain of survival. And that's the reason I stand here today. It drove me to apply for a job where I could make a change across the ambulance sector in cardiac arrest. And when I first started this job, a very prominent and eminent figure in the resuscitation world, and it wasn't Gareth, said to me, "I think your intentions are admirable, but the boldness of your expectation may be worth reconsidering." Well, I never did change that boldness of expectation, because if I did, I wouldn't be stood here in front of all of you 4 years later trying to harness the passion and enthusiasm that exists in this room and wider to make the UK world leaders in resuscitation. If you remember one thing, it's if every one of us leaves here and changes one thing, we shift the entire system. Thank you for letting me talk absolute shift. Have a look. Have a Leovili.
Great. Well, that's the end of another SCAS, which is a sad moment. It's been a brilliant day, and I just want to say a couple of thank yous before we all hit the road. Firstly, thank you to you guys for coming. Some a lot further than others, but everybody's given up time and energy and has committed to spending a day with us, which has been great. And I hope you have enjoyed it, and I hope you will benefit from it going forward. Thanks to the John McIntyre team for hosting us, and brilliant job by the AV team. It's gone almost flawlessly. In fact, I haven't noticed them today, which is a sign that things have gone brilliantly well. So well done, guys. I'll tell you what we'll do. Let's save all the applause that I know you're itching to give for the end. We'll do it all in one. So AV team, thank you very much. Thank you to all the speakers. It's been terrific to have such a varied bunch, and some people who are totally not used to speaking in this kind of context have come to share a bit of their experience, and others who are like a well-oiled machine. And it's been a pleasure to hear you all, so thank you for coming. We do give them like a little gift to go away with, but you know, a glass and a bag hardly covers it. So it's just our grateful admiration and thanks that will take you away with a warm glow in your hearts. And thank you for our sponsors who have paid for everything. We work very hard to keep SCAS free because we want as many people as possible to come. So to all the people who didn't manage to come, when you go back to wherever it is you're from, tell them next year to get themselves here. And final thank you, and biggest thank you, to the folks who've done all the heavy lifting organising SCAS over the last few days and months. Colleagues in Scottish Ambulance Service, so Shorty and Donald and Adam, who couldn't be here today because he's not very well, and Jen, wherever Jen is, probably fixing something or making sure something's working. Vicky from Glasgow Cali, and the home team in Save Life for Scotland. So Susan, and where is Dominica? Dominica, thank you so much. So these guys, as you can imagine, do an awful lot of work, some of which I don't even, I'm sure, know about, and carry an awful lot of pressure and anxiety coming up to today, but I'm sure everyone will agree with me and join me in applauding their effort because it's been a fantastic occasion. So well done, and thank you very much. And safe travels, folks.